lovely picture here. Oh, I don't know why it's not showing up there. Maybe I have to hit the button first. The joys of being the first speaker. Yep, 1 second. Hey, at least I got my slides turned in and I can see it right here. So I know this rivalry in all of sports between Ohio State and a certain team up north. Because one of my mentors in a lot of my Curie score research is from Ann Arbor, as you will learn about here in this talk. So our goals today are to understand MIBG scans and why we use them for monitoring disease in children with neuroblastoma, to define what a Curie score is, and to review what these Curie scores mean during and after treatment. I have no financial disclosures and no conflicts of interest. So when we talk about Curie scores, this is just one piece of the neuroblastoma puzzle. You have what the tumor looks like under the microscope, you have the genetics or things like McN amplification, ALK aberrations, you have the patient's age and what their stage is and what their risk category is, and then you have the scans, the bone marrows, and the MIBG scans. So when we talk about looking at how well the disease is responding and figuring out how much disease there is to begin with, we talk about response assessment. So one thing that we look at is the primary tumor. Another piece of that response assessment is looking at the metastatic disease, which is where the Curie scores fit in, and looking at the bone marrow. You put those three things together, and there we talk about the overall disease response. And that helps us decide right now. We use the overall disease response to help us decide if the patient is ready to progress on after induction therapy to consolidation therapy. I don't have to tell, I think, most people in this room, but neuroblastoma is derived from these cells called neural crest cells. And these cells are involved in our flight or fight response. And so they make these proteins called epinephrine or adrenaline. So if you think about it, when you get really nervous or you're up on stage giving a talk, your flight or fight response is kicking in. And as you're making that norepinephrine, your body metabolizes that and it gets broken down into VMA and HVA. So when your kids are getting their urine tested for VMA and HVA, that's why. Neuroblastomas come from the cells that make a lot of that adrenaline, and so it's one way that we can help track the disease. So 90% of kids with neuroblastoma will have a high urine VMA and HVA at diagnosis, but not all of them do. So in looking, why did I go into all that basic science? You guys are like, whoa, you're the first talk. That was a lot of sciencey stuff. So this is why. If you look at this molecule, I think I have a pointer. Oh, it's really faint, but this is the norepinephrine molecule, and this is an analog, meaning it looks just like it, called benzylguanidine. So what Dr. Weiland and his team from that place up north, I do have to give them some credit, did is they developed this benzylguanidine molecule, and they added a radioactive iodine in the meta position. So MIBG stands for meta-iodo-benzylguanidine. We named something in medicine that makes sense. And so we use the 123 or 125 iodine for doing scans. And if we change that iodine to the 131 iodine, that's what we use for MIBG therapy. So this is what a normal MIBG scan looks like in a patient who does not have any neuroblastoma disease. So normally, you're like, why is there stuff lighting up? You shouldn't have anything if there's no disease. Well, normally, you still have the parts of your body that are involved in the flight or fight response. So the brown fat thing is a little weird. In younger kids, you can see some brown fat. So if you see a little bit of uptake here in your younger patients or your younger children, that can be normal. That's not necessarily disease. It's normal to see it right in the middle of the face. As you can see here, that's your nasal mucosa. If you think about it, you get, dry nasal passageways when you start to get nervous or stressed, so that's why that lights up. Your salivary glands, this is one of my favorite things to teach people about. So those always light up on an MIBG scan because your mouth gets really dry, which is why I have my bottle of water up here. Your mouth gets really dry when you start to get nervous or anxious, and so that adrenaline expression is is taken up in your salivary glands. That's why it gets the benzalguanidine, or the thing that looks like adrenaline, also gets taken up in the salivary glands. It also gets taken up in the heart, so that's what that H letter is. It gets taken up in the liver, a little bit in the intestines, and then it gets excreted through the bladder. So, sorry, let me go to the next slide. So what do Curie scores tell us about neuroblastoma? Like I said, this started back in the 1990s and early 2000s, and later response to induction therapy, the bone marrow response, and overall event-free survival, meaning their risk of having their disease come back later. And then a relative score reduction, so meaning if the Curie score goes down by 50%, is that better than the absolute number at the end of induction? And initially, that's what the data told us, was that if you have a bigger drop in your Curie score from what it was at the beginning, that was more important than what the number was at the end of induction. So this is where we start getting into some of Dr. Yannick's work. We have examined now over 1,500 MIBG scans in COG studies, and we also had the opportunity to combine our data that we looked at in the Children's Oncology Group with our colleagues in Europe called ScioPen. And I was not part of the team then, unfortunately, but there was a group that got to go to Vienna and look at all the Curie scores, and then there was a group that got to go to Providence, Rhode Island to look at all the Curie scores. And then we looked at after consolidation therapy. So after transplant in patients who just get a single transplant, we saw that again, if you had a Curie score that was 0, so no evidence of disease on that MIBG scan, you did better than if you had a positive Curie score. So to summarize all of that, that was a lot of data, a lot of graphs. What do we take away from that? So on the A3973 clinical trial, which was patients with high-risk neuroblastoma who got 6 cycles of induction therapy and then a single transplant with carboplatin, etoposide, and melphalan, only that patients with a Curie score of 2 or less looked like they had better outcomes. However, we have to be careful how we interpret this data, because only 18% of these patients actually got dinutuximab, which is now what we all use, right? And the current COG standard is now tandem transplant. So does this data even matter anymore? So to answer that question, we looked at the next COG study, which was ANBL 0532. For those who don't know, that's the study that compared single transplant to tandem transplant. And we showed that patients who get tandem transplant had improved 3-year event-free survival. So we said, okay, what do the Curie scores mean in kids that are getting tandem transplant? When we looked at the distribution of the Curie scores at diagnosis, the important thing to see here is that we had patients, well, quite a few patients that had low numbers at diagnosis, and quite a few patients that had quite a bit of disease burden at diagnosis. So the median score, the middle score at diagnosis was 20. And 60% of patients had a Curie score above 18. When we looked at the end of induction, the good news is most of these kids responded very well to induction therapy, and 60% had no evidence of disease on their MIBG scan. When we looked at the Curie scores at diagnosis for the patients who got tandem transplant on this ANBL 0532 trial, we found that if you had a Curie score of 12 or higher at diagnosis, you actually had worse outcomes than if you had a Curie score that was less than 12. Now, this doesn't take into account, like I said, this is a piece of the puzzle. So it doesn't take into account your MICA, it doesn't take into account your bone marrow response, your primary tumor response, all the other pieces of the puzzle that we need to put together. And we saw that patients who were MICA non-amplified and had a Curie score above 12, they still only had about 30% of patients that relapsed. So most of those kids still did very well, even if their Curie score was high at diagnosis. So my take-home point there is, yes, this looks like scary and bad, but don't panic because this is just a small single study without taking together all the factors. At the end of induction, we found that instead of that Curie score cut point of 2, that patients who get tandem transplants have better event-free survival if they have a Curie score that's 0. So if you have any positive disease on an MIBG scan after going through your 5 cycles of induction therapy, then you have worse event-free survival than if you have a Curie score of 0. And I recently was on a tumor board where we were discussing with Dr. Tiggett from the Princess Maxima Center in Europe, and she has some interesting new data that's coming out that shows that if you combine this Curie score data with the bone and Curie scores matter. And this is another work by Dr. Yannick or Arlene Naranjo, and this shows that Curie score of 0, again, after consolidation therapy, you tend to do better. But this was only 15 patients in the patients who had a positive Curie score. So again, take all of this data with a grain of salt. It needs to be combined with other data, and we need to get more numbers of patients to really be able to answer this question. What about at the end of treatment? We are trying to look at this in the COG, but in the meantime, there was a paper by CO et al. That was published in Pediatric Blood and Cancer that showed that 150 patients who underwent tandem transplant, they looked at their MIBG scans at the end of therapy, had a Curie score of 2 or less at the end of therapy, did very well. And this comes up a lot from parents. What if my patient has, or my kid has an MIBG scan that is still positive 5 or 6 years out from their treatment? Well, a lot of times that can just be that it's differentiated, but it's no longer active disease. And this is where a PET scan or other type of scan can be helpful in helping us to know if it's actually still active or not. I think Kate Mathey told me once that she had a patient who had a positive MIBG scan for 10 years, and it finally became negative, but the disease never came back. So to summarize what we know about Curie score in kids with neuroblastoma, the absolute Curie score number matters more than the % change in the score with the data we have so far. The Curie score in single transplants, it was better if you had a Curie score of 2 or less, and this was validated in 2 separate trials in the United States and in Europe. But a Curie score that was still positive after transplant and radiation, those kids tended to not do. ANBL 1531, so the most recent clinical trial from COG that closed, that data is finally going to be released and available, and so we are going to be doing a lot of work to help figure out what Curie scores mean in this treatment era. And ANBL 2131, the current trial, has a lot of study questions embedded to help us figure out what we're doing with these Curie scores as well. And I wanted to show you this slide. This is a study by my colleague, Dr. Pinto, that shows that patients who have at least a partial response, again, this is the overall response, so looking at your Curie scores, your bone marrow, your lymph nodes and how big they are, looking at the size of your primary tumor, putting all of that together and looking at the overall response. If you have what we call at least a partial response at the end of induction therapy, your kiddos do much better. And that's what we are currently utilizing in our ANBL 2131 study to look at, okay, if the patients aren't where we want them to be before they go on to consolidation therapy or before you go to transplant, we need to intervene and we need to do something else. And Dr. Desai and her colleagues, who I think has been at this meeting before, has shown that if you give chemoimmunotherapy or MIBG therapy, or both, that actually significantly improves the ability to get that Curie score down and get the overall response better, and the kids tend to have better outcomes. So that's what we are studying on the current ANBL 2131 trial with extended induction. This was an interesting abstract that was presented at the last ANR meeting, looking at doing PCR, so that's a specific way to test how much disease is in the bone marrow. So we can look at the bone marrow and see, oh, we don't see any cells in there, so yay, it must be good. But when we look at it by PCR, which is looking at it on the very teeny tiny genetic level, we see that when you combine that PCR data with the Curie scores, it actually gives us much better information than just the Curie score alone. And so just to summarize, if you had the SIOPEN score, so Europe does things differently, they do SIOPEN scores and not Curie scores, or relapse rate. And if you have a score that's less than 3 and your bone marrow is negative, you only have a 33% recurrence rate. So what does all this mean? What questions are coming up in the future? One is, will we still even be using Curie scores? What would be lovely if we could get together with our colleagues in Europe and get rid of this SIOPEN score and Curie score and just have one way of unified testing and scoring these MIBG scans. What's the role of the SPECT-CT in MIBG scans? There's a newer modality called MFBG that combines the technology of MIBG with PET scans, so that instead of your kid having to come in the day before, get their SSKI, get their MIBG injected, and get scans the next day, they can come in, get their MFBG injected, and get the scan done the same day. So we are excited about that possibility, and it's still being studied, and we're trying to figure out what things that we see that light up matter. So lots more work to come, but that is something that we are excited about coming in the future. Can we identify patients with worse outcomes and intervene earlier, like I talked about? And can we combine the Curie scores with the bone marrow response, as our colleagues in Europe have done in that one small study? What about surgical resection? Let's say you have a little bit of MIBG positivity where you had your primary tumor. Does that matter? And then how does chemoimmunotherapy impact the Curie scores? That was a lot of talking, and I just want to take a moment to now thank, obviously, all of our amazing patients, you as the families, for entrusting us with your children and enrolling them on Children's Oncology Group and other studies, because by doing these studies, that's how we are learning about how to best take care of the kids in the future. And that's something that's so unique to pediatric oncology, and one of the reasons we all go into it. I'd like to thank all the fundraisers, the CNCF organization, our clinical research staff. Good Lord, we could not do our jobs without them. The statisticians, the radiologists, a special shout out to Dr. Yannick and Dr. Mathey and our Children's Oncology Group. This is a picture of the Neuroblastoma Children's Oncology Group Committee on a boat in Amsterdam. And then this is a picture of Dr. Yannick, myself, and some of the other people from IROC in Providence, Rhode Island, out for lunch at a COG meeting. And my final thing I wanted to leave you with is just lessons from one of my neuroblastoma patients. This is one of the things that she would always tell us when we were having a rough day. Dry your eyes, go do something fun, live your life, enjoy the time you've been given, be kind, and love fully like it's your last day. And with that, I will take any questions. It's the first talk, it's okay. Coffee's still kicking in. Sure.
Just wondering if you could add any insight into patients at diagnosis that are non-MIBG avid, or if that means anything from your perspective that you've seen.
So we don't know that if, that's a great question. Thank you very much for asking, by the way. We don't know that if you are not MIBG avid, it means that you do better or worse. And we have not yet looked at the PET, so we do PET scans, right, when you're, when you're not MIBG avid. And there's not a Curie scoring for PET scans. We just kind of count the number of lesions in some way and kind of try to make it fit into Curie scoring, so that is definitely an area. If this MFBG thing doesn't come on, which I have a hunch it's going to, that is definitely an area, and it's an area we need to pay attention to now, right, for the kids who are MIBG non-avid. We don't have a great standardized way of evaluating those responses. But we are doing sort of the best we can with fitting it into a Curie score.
Following up on that question,
Yeah.
is there a way to, I don't know, identify that you're not avid? Is it just kind of like trial and error that, hey, nothing's showing up on MIG, let's try a different scan? Or is there, how do you find that out, I guess?
So we usually start with an MIBG, and also, great question. We usually start with an MIBG scan, and if we see that there is no uptake in the primary tumor, then, and we know that that primary tumor is neuroblastoma, then that tells us that the rest of the disease that we're looking for with the MIBG scan is probably not going to take it up. And so then we would switch to a PET scan. And as a mom who has a kid that's, I'm assuming, that MIBG uptake can change over time, because those proteins that take up the MIBG dye can be downregulated over time, and so you might not always have a reliable MIBG scan. So if a kiddo has relapsed even once and nothing's lighting up on the MIBG scan, but they're having leg pain or there's something that looks funky on the MRI, we'll get a PET scan. So that's kind of how we decide which type of scan to use moving forward. Does that answer that question? Okay.
I had a quick question. When does MIBG, I hear different things about it in remission, like being standard versus not being standard, to continue doing them?
Sorry, repeat your question again.
How do you determine in remission when MIBG scan is still like part of the standard for scans?
Got it. So that is a great question. There is if a patient is enrolled on a clinical trial, there is a minimum recommended number of MIBG scans that they need to do. On the current study, for example, it's every 3 months for the first year, then every 6 months, and then just one more time at year 3. And then we don't do MIBG scans after year 3 unless there's clinical concerns. And that's just because 97% of kids, if they're going to relapse, that happens within the first 3 years. So why put them through that radiation exposure if they don't need it? Now, having said that, have I had patients where I am really concerned about their risk of relapse and I want to just get that one more MIBG scan at year 4 or 5? Yes. And sometimes working with and partnering with the parents and helping them to understand, we'll sometimes get just 1 or 2 more MIBG scans, but we do have to stop at some point. Unless, and the other piece that helps with that is as the kids get older, they're more able to tell you if something hurts or if something's off. And so that kind of helps ease us into knowing that we don't have to keep doing the MIBG scan as often. I love it. Keep the questions coming.
So back to the MFBG scan. I've been coming for a number of years, and I keep hearing how excited everybody is. But again, a number of years, right? That keyword. It came out in 2018. We're now 8 years since it came out. When is that going to be available to stop being so invasive in our children? Everyone's talking about the MIBG and how it's not in certain, children. But the MFBG will help with the PET and the MIG to help determine that outcome to see more of the disease in children. So is there a timeline instead of just being super excited? I'm sorry, but it's just like...
Nope, very fair question.
Yeah,
and
thank you.
It's much like drug development in pediatrics. Because it's such a rare disease, it takes us a long time to get the numbers that we need to show the FDA that this is the thing that's going to move forward. That's going to be the next thing we need to do in our kids with neuroblastoma. And I've been involved on the back scene or the behind the scenes of trying to help get this thing through. And I've heard how the FDA just says, that's not enough, that's not enough, that's not enough. So we're trying, and I'm hoping is coming. Now, to clarify, if you don't pick up MIBG, you're probably not going to pick up MFBG either. So it's not really going to help those patients who just are MIBG non-avid, and it's just going to make things easier for those who are MIBG avid. So we really need to look at the how to do Curie scores on PET scans. But yes, I don't have an exact timeline. I can just tell you we are trying. That study is still ongoing because the FDA keeps asking us for more information.
Is this on?
Yeah, this is a very complicated disease, like most cancers are, and this is rare. So then the question I have is, centers that focus on neuroblastoma, and you would compare their success rate or their effectiveness in treating cancer to centers throughout the country that do not have that kind of experience, may see one or two. Has there ever been a study done comparing the centers, the big centers focused with maybe the majority of the country that may not have exposure to neuroblastoma? They see one or two. And I would imagine that there would probably be a big difference in results. Has there any studies looked at that?
I don't know that we have done a study to look at exactly that, but what I can say is, having been involved in a COG clinical trial now, when those smaller centers who maybe get one neuroblastoma patient every 5 to 10 years get a patient with neuroblastoma that they're putting on this trial, or even if it's not on the trial, they just have a question about how to give a patient dinutuximab or nixitamab, they're calling and emailing the bigger centers. So I don't think that we're compromising care in this era, because we're all so connected with emails and phone calls, and but it is a good question, and it could be something interesting to look at, but I don't know that we've done any studies.
Thank you.
Oh, is that mic not working?
I don't know. Back to that, the MFBG, since I was also very interested. I reached out to the CEO of the Innervate Radiopharmaceuticals. And the last email I got from him on June 1st was that they expected to file with the FDA in August or September. Is that not, do you have more current information that you're telling me?
I definitely do not have any additional information than a company would.
I think there's, the issue of there's a private company that owns that technology and is responsible for the next step.
I don't think that's an issue at all, because having talked with the people from that company as well, they are so committed, much like all of the companies that are sponsoring this. They are so dedicated to our patients and doing everything they can to move it forward. I don't think that's the issue.
Okay. Just as a point of information on your Curie score thing, my son still had a positive Curie score at the end of his induction, but they did additional cycles of chemoimmunotherapy with dinutuximab before his BMT, and he was cleared through that. But he has relapsed 3 times since the end of treatment. So he was
at the beginning, adding it with induction
treatment, he might have been clear, but it didn't mean, since his response to chemo itself was visible.
refractory solid tumors, which neuroblastoma is a part of. As most of the people in this room know, the standard of care for high-risk neuroblastoma consists of induction with chemotherapy and surgical resection, consolidation, which has 1 or 2 transplants with radiation, and then a course of immunotherapy with isotretinoin. This is all based off of the COGS study ANBL 0032, which resulted in that addition of the immunotherapy at the end to the standard of care. The Throughout all of these advances, though, we've realized that it's really the cancer stem cells that seem to be the most resistant to any of the treatments that we're able to author, whether chemotherapy or radiation. And so from that, birthed a focus on something called DFMO, which targets one of the pathways in these stem cells to reduce the polyamines within the cells. This was carried out through clinical trials and ended up showing improvement in event-free and overall survival when added onto the end of therapy for patients with high-risk neuroblastoma, and was FDA approved in December of 2023 to prevent relapse for high-risk neuroblastoma patients after they received immunotherapy. The BCC-020 trial takes this a step further in looking at that same pathway that we know DFMO improved when we were able to target that, and then tried to expand and think about, are there any other parts of that pathway that we can try to target at the same time to hopefully improve the response even more? Whoops. So we know DFMO improved when we were able to target that, and then tried to expand and think about, are there any other parts of that pathway that we can try to target at the same time to hopefully improve the response even more? Whoops. So that's exactly what AMXT does. Essentially, the main target being polyamines. The cancer cells have polyamines within the cancer cells, but they can also take from the environment and bring into the cell too. So the DFMO takes care of the pathway targeting what's already in the cancer cell, but AMXT actually targets the polyamine transporter that is crucial to the cell to be able to take any more in. And so the hope with combining these two is we're going to be able to reduce that polyamine load even more and be able to improve response from that. This is as part of the phase 1 study of this, it's going to be evaluating that safety, tolerability, and the recommended dose going forward for the phase 2. Both DFMO and AMXT are going to be oral medications that they take. Now, if anybody was here last year when Dr. Scholler had talked about this, or you had heard of previous iterations of this trial before, the initial thought was that the DFMO was actually going to be delivered in continuous IV infusion along with an oral AMXT, because there was concern that there could be GI toxicities if you took both of them orally. The adults had a trial already open, and when they tried that continuous IV formulation of the DFMO, they actually realized that the concentration of that drug ended up being about It uses the standard of care backbone right now in all of the COG studies, which is the 5-cycle backbone, and it just adds naxitamab on top of that standard of care that patients are already receiving. There is no change to the remainder of their care. There's no addition to the remainder of their care on this study specifically. The newest addition that we have just added into this BCC-018 study, which is of my particular interest, is collecting stool samples to be able to characterize the gut microbiome in patients with high-risk neuroblastoma. So what is the gut microbiome? I feel like it is something that is talked about a lot now, and we're starting to learn a lot more about it. But essentially, it refers to the fact that your entire GI tract from mouth to bottom is filled with trillions of tiny organisms that make up this whole community going on within your body. And the majority of what we talk about when we mention gut microbiome are bacteria. Now, a lot of us are trained to think bacteria is bad, and they obviously, when they are in the wrong place at the wrong time, can cause very bad infections. But not all bacteria are harmful, and not all bacteria in small numbers are harmful either. So a lot of people are familiar with C. diff infections. Every person actually has C. diff bacteria living within their gut at all times. It becomes a problem when that number starts to outnumber the helpful bacteria that are around it. And so we really talk a lot about balance and making sure that we're keeping this microbiome happy and balanced and in check with each other. They really form, this microbiome is one of the body's first defenses of health. If we think about all of the different insults we have in our body from environment, from things that we're eating, this really is helpful with digestion and the gut barrier. It actually communicates with the immune system. There's communication up with nerve communication to our mind. There are so many things in the body that the gut microbiome can impact, and it also can be impacted by so many things out there that we're trying to parse out this kind of newer pathway that we're looking into to see all of the different ways that it can affect us. And specifically in cancer treatment, how is it affecting patients' toxicity levels with medications? How is it affecting how efficacious they are? Well, the last bullet point there is just to put it in context. All of the different organisms with the gut microbiome weigh about as much as your brain would all together. And so they're kind of spread throughout, but it is a very large system to be talking about. I really like to think of the gut microbiome like a neighborhood. And if you think about your neighborhood and you think about your neighbors, everyone kind of has different roles in the neighborhood. Like you have somebody who can help mow lawns. You have somebody who always has the backyard barbecues. You have people who just naturally take different roles, but you all work together and you form the neighborhood that you live in. So when I think of gut microbiome, there are some neighbors that will help digest foods. There are some that keep unwanted visitors away. There are some that help train the immune system. And we know with the gut microbiome that the healthiest neighborhood has a lot of different kinds of these good neighbors all helping together. And we know that there are problems when if too many of the helpful neighbors leave, then that neighborhood becomes less balanced, and that's when there are problems that can happen. Now, these changes can occur with exposures to medications, different food exposures, a changing environment. This is a living and breathing neighborhood that will adapt to whatever it is currently experiencing at that time. An altered gut microbiome composition has been linked to multiple cancer types. Dysbiosis, which means reduced microbial diversity. So when we look at describing a gut microbiome, it's not just listing what types of organisms are there, but it's also looking at how diverse, how many different things are in it. And we know that reduced diversity has been strongly associated with an increased cancer risk, alterations of how well chemotherapy can work, increased chemotherapy side effects. Now again, these are all strongly associated with. There's not any large trials yet, or there's not many large trials yet that have looked at this on a large enough basis to be able to draw specific conclusions from this, but there's enough data to suggest that it is worth looking into further. For neuroblastomas specifically, there's been an altered gut microbiome reported in murine models with neuroblastoma, and then there was a small Italian cohort of patients with newly diagnosed neuroblastoma where they actually compared the gut microbiomes of the newly diagnosed patients to their siblings as a control, assuming that they are part of the same environment, the same food and everything. And they did show that there were altered patterns with the patients who had just been diagnosed compared to their siblings. So the objectives of this part of the, did somebody have a question? Sorry. The objectives of this part are really descriptive in nature. So we're going to be describing the taxonomic, which is just the list of what types of organisms there are, and the functional characteristics of those organisms in patients with newly diagnosed high-risk neuroblastoma. We're then going to be following through to see if we can elucidate any changes that happen to the gut microbiome during induction treatment with that addition of the nexitinib throughout the end of immunotherapy. The participants in this are just if you are enrolled on the BCC 018 with nexitinib, there's no additional inclusion or exclusion criteria for the sample collection. It's just part of the recommended sample collections. We are looking at stool and blood samples at 6 time points. One is pre-therapy start, so just at diagnosis before you've received any chemotherapy, and then post-cycle 1, seeing how quickly, if any, changes occur, post-cycle 4 and post-cycle 5, thinking this will give most patients finished with induction, and then most patients finished with surgery too, to see if that impacts, and then pre-standard immunotherapy and post-standard immunotherapy. We're really trying to see where different time points happen and if we're able to elucidate any patterns that occur with that. It's stool sample collection, which is just home collection, and then being able to get it to your center, and they get shipped over to our microbiome center at Penn State Health. We're also doing blood samples to be able to look at the metabolomics data too. So the stools will give us a descriptive characteristic of what's there. The metabolomic blood piece gives us the so what. So we know that the bacteria is there, but is it actually doing anything in the body? And it's able to look at more of the downstream effects and give some richer data from being able to look at not only the names and the diversity, but also the function of the impact it's having on the body. Mention that. So with this, as I mentioned, this is a first step of just description characteristics. We're not having any intervention with it. This is just that first step of gathering that baseline information to then hopefully be able to, once we see these patterns, be able to spur, okay, now that we have this initial information, what can we do next? And so the hope is that if we identify common themes of patients with newly diagnosed neuroblastoma, patients with different responses to therapy, patients that experience different toxicities, if we can start to find patterns there, then the next step is, okay, well, if we see that there are patterns, is there a favorable pattern that we can say, okay, all these patients who had this sort of gut microbiome seem to have better responses or seem to have less toxicities? Are we able to figure out how to then alter a patient's gut microbiome? So we know that it changes all the time based on what it is introduced to, but are there things that we can do to start trying to induce that change? Some of you may have already heard about in adults, there are some indications for fecal transplants, like for recurrent C. diff infections and things like that. There are a bunch of different delivery methods for this. One of the difficult pieces is some of the delivery methods that are often used are suppositories to be able to change this, which, as we know in our patients who are immunocompromised, we're not able to use. But they have different ways of doing fecal transplants. There's also, I say newer, it's probably been at least 5 years or so, they have very aptly named them crapsules, which are essentially dried fecal matter in capsules that people are able to take and then be able to populate the entire GI tract. One of the difficulties is there are a bunch of different areas within the gut tract, and you need to be able to target all those different areas to try to be able to change. So we have a different microbiome in our mouth and in our small intestine than in our large intestine. And then if we figure out that we're able to actually alter it to what we want, then you follow it through and say, okay, but did that intervention then lead to a more desirable outcome? If we find a pattern that exists in patients who have really severe mucositis, are we able to alter that in a way to then reduce the risk of mucositis? And is this a supportive care thing that we can be doing for our patients as they're going through chemotherapy? That last bullet point there is one of the things that I really love in just a kind of integrative oncology approach in general is I think a lot of our research, for good reason, has been very focused on tumor-specific characteristics. What are the genetic patterns that put somebody at higher risk? What is the distribution of the tumor that puts somebody at higher risk? That means they need to get more chemo or they're at higher risk of relapse. And we are, I think, just starting to realize the value in looking at, are there person-specific and patient-specific things that could be also contributing to this? Because yes, you have a tumor, and you have a tumor that gives us indications of what treatment it needs to be able to fight against it. But we also have a person that tumor is in, and that person already had its own little microsystem of how it reacts to things, of how it processes through things. And so I really believe that being able to meld both of those sides together is going to be one of the next biggest leaps that we're able to do in cancer treatment in general and in neuroblastoma. So I'm going to wrap up with this final slide of a lot of what we hear about, and one of the parents touched on it earlier today already, is okay, well, we keep hearing about all these great things that are coming in the future. what can we do now? What are things that we can help now? And I've recently been really lucky to be able to start a pediatric integrative oncology program at Penn State Health, in which we're able to have dedicated appointments with our patients to talk just about these integrative things. What are things we can do? And so I wanted to leave you guys with just general, whether you have neuroblastoma or not, general things that we can do to support a healthy gut microbiome, and things that we can already be incorporating with our patients and into our talks and into the things that we're thinking about to be able to support this as we are finding out all of this data going forward. So the first thing that you try to do is minimize unnecessary disruption, which unfortunately is impossible when a child has cancer, because if you give any medications that are going to disrupt that gut lining, it's going to be affected. If you give antibiotics, it's affected. And we know that these things are necessary. So then it changes to look at, okay, well, if I know that those necessary changes are going to happen, what are things that we can do to support it? And I really bring it oftentimes back to nutrition and really looking at trying to use food as medicine in this case, and really looking at, we talk about diverse whole foods, making sure patients are getting their daily fiber, and looking to different food sources that are higher in concentration of both prebiotics and probiotics, things like fermented foods, yogurt, kefir, and if people don't like the taste of that, being able to hide some of these in smoothies is a really good way for kids to be able to get them. And we just know that there's so much that alters in a kid's environment when they're diagnosed with cancer. Just moving from a home environment into a hospital environment, your body is exposed to different organisms, and it alters just being in the hospital. And then typically most hospitals do not have, I'll say, the same caliber of food as we necessarily do at home, and so then you're impacting it even more as you go through that. And so just trying to build in supports where we can to put up guardrails to that change in environment can be really helpful. Okay. I will end there. Thank you guys. I think this is really exciting. It's a really exciting frontier. So I'd love to hear if anybody has any questions.
For children that are tube fed or NG tube fed, do you have any recommendations to help support the gut microbiome?
Yes, and thank you for that. I think that's also one of the biggest alterations we have too. So if patients are G-tube fed or NG tube fed, you can make home, you can essentially blend up whole food meals. We have some patients who will have recipes to be able to get some of these things in. Sometimes it is figuring out the logistics of getting it through a tube, but there are soups, it mainly becomes soup to be able to get it through, and working really closely with your dietitians to see how you can deliver that alongside the formula tube feeds. I think it would be very difficult to be able to deliver all calories necessary based on homemade soups or smoothies or anything like that. And so oftentimes it does have to be a combination with both. But there are ways to be able to do it, and we've definitely seen it be helpful, especially in those circumstances.
MD Anderson last year reported they had success with a coach that had stomach cancer, and they transferred microbes from an adult that did very well after treatment, and I think they were using checkpoint inhibitors. Have you identified any microbes that are associated with kids that did well as opposed to the kids that do not do well?
Not yet in pediatrics, and that's what I'm hoping that we're going to be able to see. These kind of descriptive studies really don't exist, especially for that endpoint of patients who have gone through cancer and we see how they respond. There are a few starting for the patients who are newly diagnosed, but being able to follow it through, it's not there yet for pediatrics.
Okay, thank you.
Hello, Amalia Gonzalez. I had a question about the trials that you put up at the beginning,
Yep.
BCC 20, 21, and 22. Are you actually recruiting children for those trials now?
Yes, those trials are all open right now.
And are all the centers that are part of the BCC recruiting?
To my knowledge, yes.
Okay, awesome. And also, is there an update? I believe it's also a BCC trial, the B7H3 CAR T?
I don't think that's BCC.
No? Okay.
No.
Thank you.
Hi, I have a question going back to when you're talking about gut support. Working with a well-known naturopath in the pediatric cancer, I believe he's also worked with Scholler, but I'm hearing for neuroblastoma kids, these naturopaths put them on like a neuroblastoma diet, which is ultimately a low polyamine diet. And I feel like on there, one of the big like restrictions was avoiding probiotic or fermented foods, which would kind of just go in contrast with sharing. So I'm wondering if you have anything to add about that.
Yeah, and so I've seen the thought process, especially with talking about that pathway, like we were talking about with DFMO. Can we restrict? The data that I have seen, I think a restricted polyamine diet is really hard. I think it is hard for a kid to agree to, and I think it is hard to ensure that we are actually supporting other parts in their body while they're doing the restricted polyamine diet, which is why I like the approach of seeing if there are other ways that we can use medicines like AMXT and DFMO to be able to target it that way. That's okay.
Yeah, Dr. Scholler spoke previously about different trials, especially the PEACH trial, and others that are looking into producing like vaccines and some even more complex. Can you just give us an overview of if there are children enrolled on those trials and where they are at the moment?
Yeah, absolutely. So for the PEACH trial, which patients with neuroblastoma are eligible for, it is expanded outside of just patients with neuroblastoma. But there are patients who are actively enrolled in that, and essentially they get we call it MGT, so molecular guided therapy built treatment plan for them as their vaccines are being developed. We have multiple patients through our center right now who are enrolled on it and receiving.
It's my understanding that Sloan has identified microbes that are affiliated with the kids that do well. And have you heard anything about that?
I have not. I have not aware of any of the data on the back end of it. I'm hopeful. I know that there are a lot of centers that are focused on this right now. I think it's incredible that it's been recognized as a really important piece of the puzzle. And so I'm thankful that a lot of different centers are looking at this. I anticipate over the next 2 to 5 years, we're going to start getting a lot more information out there about it.
Thank you.
No other questions? Okay. We're going to go ahead and take a 15, 20-minute break. They're still setting up our snacks, so take your time, go to the bathroom, do whatever you got to do. Thank you. Hello, everyone. Can we go ahead and get started? Kind of loud. Okay. Our next speaker is Kristen Smith. She's the program manager for fertility preservation, consults with all the young and newly diagnosed oncology patients at Northwestern Lurie Children's. And she works to help with each patient understand their individual fertility risk associated with treatment, as well as options for fertility preservation. She works extensively with young adult oncology survivors to help each patient explore their unique family building options and reproductive health post-treatment. Kristen helps run the Onco-Fertility Professional Engagement Network of the Onco-Fertility Consortium by providing support across the world to providers who participate in the network, and also answers the National Fertility Hotline and email to triage patients for fertility preservation across the United States. Kristen has spoken here a couple of times, and we just love having her come back. So Kristen Smith.
Hi. Thank you so much for having me. I was actually, I'm in the Chicago area, and I was trying to remember how many times have I been here, and I think it's been about 7 now. So super thrilled to be back here. I just want to let you know, too, feel free to interrupt me during this talk. Feel free to raise your hand, shout something out. I'm more than happy to stop at any time. And I'm also going to provide my email at the end of this, so if you've got questions or something didn't make sense, please don't hesitate to reach out to me and email me. I'm more than happy to chat any way that I can. This screen, wow. Can we talk about this gigantic screen? It's pretty impressive. Let me just make sure I know how to work this. There we go. So at Northwestern University, which is in downtown Chicago, this is really where the kind of term oncofertility was born, and it was born by a reproductive scientist by the name of Teresa Woodruff. So back in 2006, she received an NIH roadmap grant that really enabled these two worlds to come together. And what we've seen, really over the past sort of 2 decades is that oncofertility is increasingly becoming a part of the conversation at the time that someone's diagnosed, and should also now be part of the conversation in survivorship as well. Once we started the Onco-Fertility Consortium at Northwestern, we created what was called the National Physicians Cooperative, which was a group of about 60 academic medical centers around the U.S., really focused on ensuring that we were actively providing this type of care to our patients, to our survivors, to our families. And now this is expanded across the globe in what's called the Open Network. So across the world now there are researchers and scientists and clinicians all working together to ensure that we understand the ways that treatments impact fertility, that we're working on fertility preservation options and use of those gametes in the future. This is just a really nice timeline of sort of how oncofertility has come about within the United States. It really, adolescent and young adult oncology started to, really become prime time within the world of oncology back in the 2000s. And then kind of each year we've just started to see more organizations addressing fertility preservation. We've started to see laws being passed. And the last part of my talk is going to be on some advocacy and some laws that have been passed within the United States over the past sort of decade or so. And then sort of what options have existed for fertility preservation, which we'll dive into. So this is just some general statistics about overall adolescent and young adult oncology. And this all comes from the SEER database where they track things like this. So the NCI designates AYAs as ages 15 to 39. So this is sort of the group that's encompassed within these numbers behind me, really breaking down sort of new cases based on diagnosis, as well as distribution on death rates based on diagnosis. What's important for general AYA survivors, though, is that we're starting to see the relative survival rate go up and up and up, which means that more of our patients, more of our survivors are going to need to have access to fertility and fertility preservation. This is just a breakdown of all the different types of cancers by sex. And I think important to note here, I'm going to be talking about options for males, options for females. Typically what I'm referencing for males is those that were born with testicles. For females, I'm referencing those that were born with ovaries. But I certainly am well aware that that doesn't encompass all males and females, but for this purpose of this talk, that's kind of how we'll categorize that. And what we've seen happen across AYA oncology is that there were these sort of key pieces that were published back in the early 2000s of what a comprehensive program needs to have in order to best serve our adolescent and young adult patients. We need to have access to clinical trials. I think this group knows that better than anyone else. We need to be able to have our children, our family members have access to clinical trials so that we can be at the break point of all the latest and greatest treatments that are coming out there. We need to have psychosocial support for our patients and our families. We need to be able to understand our own health insurance and get financial counseling as that's needed. And we need to have this amazing transition to survivorship care, where we can ensure that we as survivors, we as patients are getting the care that we need long-term, not just in this acute setting. Clearly, fertility counseling, that number 2 piece, is like my whole bread and butter, so that's what we're going to focus on, but all these pieces are so important. When we look at guidelines that now exist for fertility preservation, we have a lot to choose from. So basically, every large medical organization has put out something now that says, hey, we have to be talking about sperm banking, egg banking, ovarian tissue banking when someone's newly diagnosed. Now some of these organizations are putting in survivorship guidelines as well, that this needs to be a continued conversation, not just something that happens one time. So I'm going to take you all back to like 7th grade health class. I think this is when we learned how sperm were made, right? So when sperm is made, it all starts in the brain, okay? So the pituitary gland is sending out different hormones. Those hormones are telling these specific cells within the testes to start to make testosterone. That testosterone is then also helping to stimulate cells that support spermatogonia cells. And the spermatogonia cells are the ones that then make sperm. So if at any point this pathway gets disrupted, we know that that can impact someone's ability to physically make sperm. And when we think about what chemotherapy does in particular, we don't really see chemotherapy impacting those cells that are responsible for testosterone production. But what we do see is that chemotherapy can also sometimes destroy the cells that help support the spermatogonia. Those were those cells that make sperm. And when that happens, what we see is that sperm production either goes very, very, very low, or in some cases goes away completely. And there are certainly cases where this is temporary, right? So we have this initial hit to those cells that support those spermatogonia cells. We see sperm production go away, and there are some cases where we see sperm production come back. So the stem cells of those spermatogonia cells kind of hang in there, and we start to see sperm production come back sometimes about 6 months to a year, even a little bit later post-treatment. What we're able to do now is really have some great risk stratification for how high risk is someone's particular treatment. And a lot of this comes out of our partners at St. Jude. So St. Jude, as you guys all know, has this childhood survivorship cohort that they've been following for decades. And what they did when it came to fertility was they went back to all their patients who are now adult survivors of childhood cancer that would come in and do a semen analysis. So they had about 214 that said, yes, I'll do this. And what they did then was go through their treatment plans and created what's called a cyclophosphamide equivalency dose calculator. So this is a way that we can now calculate a total cumulative dose of alkylating agents that someone's received in terms of chemotherapy, and we can essentially assign a score to it. And that score then helps us sort of figure out how high risk is this patient's treatment going to be. And what we saw was that sort of for men, 4 grams per meter squared of cyclophosphamide equivalency dosing was sort of that breaking point. Once we started to go above that, we started to see long-term impacts to those spermatogonia cells and the body's ability to make sperm. I think it's a no-brainer, right? If someone's getting radiation directly to the testicles, that's going to impact those cells. That makes a lot of sense. What we don't always think about is if someone's getting cranial radiation in particular and interrupts that pituitary gland and the way that gland sends that additional signaling, if you remember from that previous slide, and we stop those hormones from being sent, that body is not able to make sperm because it's not getting the signals that it needs. Interestingly, when we give testosterone to someone, so when someone starts to take testosterone injections or things like that, or has a pill, that actually further impedes sperm production. So giving exogenous testosterone actually does not help with sperm production whatsoever. And I think that's really important to note. We especially, I'm sure you've heard all about it in the media lately, lots of talk about giving men testosterone, right? that actually really directly impacts fertility as well. So all these tests need to be done, and we'll talk about what tests to look at down the line before we start giving some extra hormones to our male survivors. This is a lovely table that the Pediatric Initiative Network of the Oncofertility Consortium has put together. So they've created these risk stratification tables that now can help guide, in particular, pediatric oncologists about the risk that treatment will have on future fertility. And you can kind of see, we talked about that CED, that cyclophosphamide equivalency dosing. They break it down into less than 4 or greater than 4. And that's really that breaking point of where we're in a minimal risk of long-term infertility versus more of a permanent risk of long-term infertility. Now we're going to talk about females. It gets a little more complicated. So as females, different than men, we are born it's a lot. When women are born, they have about 1 million follicles. Time of a menstrual in the United States is when most women end up going through menopause, but really our fertile window is even shorter than that. So most women are kind of done having babies in their 40s, and that's largely because the eggs that are left are just not competent enough to create a live birth. So women are really faced with not only quantity of eggs, but then also quality of eggs. And what you see here is just a picture of like what the reproductive system looks like. Sometimes I have to really explain this to patients. And then I also included just what a general menstrual cycle is doing. So that's kind of this picture over here, where typically the brain is sending follicle stimulating hormone. One follicle from a pool of follicles takes all that FSH, that one follicle grows, the egg inside it matures, that egg ovulates. If it's not met with sperm, a period happens 2 weeks later. And the reason that I explain that is because what happens when someone's exposed to chemotherapy is that those cells that help support the follicles really get destroyed. And it sort of wipes out the whole pool of antral follicles that's sitting there. The body then recruits a new pool, and then that pool gets wiped out, and a new pool, and that pool gets wiped out. So it just causes a patient to really burn through her follicles much, much faster than she normally would. Abdominal radiation as well to the pelvis can have a lot of impacts, not only on egg count, but also a lot of impacts on the uterine cavity that's sitting there. So we know in someone who's received high-dose pelvic radiation, sometimes it can be really difficult for them to physically carry a pregnancy down the line. Maybe it means the lining of the uterus doesn't grow the way that we would want it to. Maybe it means the blood supply to the uterus isn't what it needs to be. We know that when women have been exposed to pelvic radiation, they have higher rates of miscarriage. This is that males, but now for females. And I think what's important to note here is that we see that when girls are prepubertal, so before they've started their periods, that's actually a bit of a protective effect against chemotherapy. So you can see here that it is delineated between prepubertal and postpubertal in terms of risk. And when a patient is prepubertal, what we're finding is that their body can take a lot more chemotherapy than a postpubertal patient. So being prepubertal actually has a bit of a protective effect in terms of fertility for all of our female patients. This is another way to kind of look at all that, just in sort of a graph. So kind of showing born with all those follicles where we're going to have that sort of curve that falls down to essentially menopause when we've exhausted all of our follicles. And then if someone's exposed to chemo or radiation therapy, what we see is sort of this direct hit and the movement of that line down. So it doesn't necessarily mean that as soon as someone's received chemotherapy or radiation that their fertility is completely gone in this circumstance. It just may mean the time they would have to pursue fertility preservation or the time they would have if they're ready to get pregnant to pursue pregnancy is going to be shorter than it otherwise would have been. And so when we think about, particularly in neuroblastoma, we know that so many of you that are sitting here, so many of your children, have been exposed to high-dose chemotherapies. In some cases have had stem cell transplants, maybe a tandem. And so we know that in a lot of these cases, these are high-risk treatments that are gonna have a lasting impact on fertility. For some patients that have received just chemotherapy alone, maybe not as high risk, but we're gonna talk through kind of really what to look at when you, if you're ready, wanna talk to a reproductive specialist about your current fertility status and what's next steps for you for family building. So who are these people, these elusive reproductive specialists? I really have two groups that I work with. So one is reproductive urology. And these in particular are urologists. So they've gone through their residency as a urologist, and then they've gone on to what's called fellowship training, specifically for reproductive medicine. And these urologists will do a phenomenal job at seeing you to talk about sperm production. So they're gonna do a full history and physical, just like you get at every doctor's office. They wanna see sort of your previous health history, talk about what your treatment plans were. They're gonna do blood work, so they wanna measure hormones. And in particular, they wanna do these early in the morning. That's the time that testosterone peaks. So they're gonna look at testosterone, but they'll also look at the hormones that come from the brain, that follicle stimulating hormone, luteinizing hormone. Sometimes they're looking at prolactin, estradiol. And then they'll likely order a routine semen analysis. So this is where you go into an office, produce a sample. That sample gets analyzed under the microscope. And what we're looking for are, number one, are sperm present? If they are, we're gonna do a full count. So how many million per milliliter are present? We're gonna look at the motility, which is how the sperm are moving. And we're gonna look at the morphology, which is how the sperm are shaped. And then based on that semen analysis, if sperm are present, that reproductive urologist can really talk you through, okay, how can this sperm best be used for family building in the future? I think also important to note, I have some patients who just assume they're infertile and they've been having unprotected intercourse because they just assume they're infertile. So I love for my patients to get a semen analysis so that we really know, so that we are also avoiding an unwanted pregnancy and can talk about contraception. What are some fertility preservation options? So I know for most of you this is long past, but I just want to put these in here so that if you're talking to new families, someone who's newly diagnosed, you can sort of offer maybe some suggestions for them if their healthcare provider has not brought up fertility and fertility preservation. So for post-pubertal patients, certainly sperm banking is the gold standard. It's that same routine semen analysis, but instead of then discarding, we're going to freeze some of that sperm for future use into multiple vials. And then each vial of sperm is an option at an assisted reproductive technology cycle, whether that's an intrauterine insemination, whether that's an in vitro fertilization option as well. We can also do something called an oncotesy. So this is for my patients who are not physically able to ejaculate. We can actually surgically go into the testicle. We can remove part of the testicle and actually find sperm within the testicle and then freeze that sperm. When we're doing an oncotesy, we're getting very, very low numbers of sperm, but we can utilize IVF in order to create a pregnancy in the future. And then for both post and pre-pubertal patients, so for our patients who aren't yet making sperm because they're too young, we can now offer testicular tissue freezing. So this is where a wedge resection of the testicle is removed, typically at the same time that we're gonna do like a line placement or any other type of surgery. And that tissue gets shipped off typically to a guy in Pittsburgh named Kyle Orwig, who's really running all the testicular tissue cryopreservation throughout the United States. And so what he does is he saves that tissue with the hope that in the future he'll be able to take that tissue and populate it back into the testicle when that patient's ready to try for a pregnancy. The body sort of recognizes its own tissue and will hopefully start to make sperm again. He's had success so far in non-human primates, and we've just started to have some patients come back who, froze their testicular tissue 15 years ago and are now ready to build a family, come back and see him for these procedures. So we're hopeful to get some really good data out of that really soon. There are certainly other options too. So if you live somewhere where you don't have access to a reproductive urologist, if you just don't want to, what I find here, I have a lot of people who are like, I am not traveling into downtown Chicago to do this because traffic is the worst. I get that. There are certainly mail-in kits as well, so both for banking and for semen analysis. So Reprotech is a long-term storage company that does long-term storage of gametes, offers discounts for cancer survivors. They have an overnight mail kit. They've partnered with the University of Illinois here in Chicago to offer that kit. It gets shipped to your house. There's also another group called Fellow. So they'll send out a kit right to your house. You collect into that kit, you send it back to them. Their semen analysis is $199. And then their freezing did just go up. The cost of liquid nitrogen, I guess, has increased significantly in the past year. So their yearly storage fee, if you want to store sperm, is about $240 per year. So those are some other options if you're interested in just a general semen analysis without going physically into an office. Now, if on the female side you're wondering about your current fertility status, we would encourage you to see a reproductive endocrinologist. And you can find these particular specialists who are OBGYNs, then went on to do 3 years of reproductive endocrinology and infertility fellowship through our sort of professional groups, which are the American Society of Reproductive Medicine. They'll have a really nice list for you. And then if you want to look by clinic, so you can go into what's called SART, the Society for Assisted Reproductive Technology, and you can actually pull clinic names up, and then you can see all their success rates for their IVF cycles. And that kind of gives you a good idea of sort of who's offering what within your particular area, and a little bit of like how good are they at what they do. When you go see an REI as a patient, they're definitely going to want to have records on what previous treatment you had. They'll want to talk to you about your family building goals, your reproductive health goals. They'll do, again, a history and physical. They'll also do blood work. So looking at some of those same hormones we just talked about, follicle stimulating hormone, luteinizing hormone, estradiol, now also looking at progesterone, also something called anti-Mullerian hormone. So this is a hormone that sort of came to market about 2 decades ago now. And essentially, anti-Mullerian hormone is a hormone that's secreted by cells that support growing follicles. So by getting that measurement, we can get a really good look at someone's current ovarian reserve. And importantly, this is a level that we can track long-term to see how is the ovarian reserve declining if it is. We also like to do an ultrasound. So oftentimes this is a transvaginal ultrasound where we insert a transducer vaginally to visualize the ovaries. If that's really uncomfortable for someone, we can also do an abdominal ultrasound. And then we're going to schedule follow-up visits. And there may be additional tests that we're recommending, like a DEXA scan, which is looking at bone health. We may send off for endocrinology consults to just talk about thyroid stimulating hormone and different things like that. But working with an REI can really help you figure out all this initial information and then come up with a plan for follow-up. When it comes to fertility preservation options for female patients, we can certainly, in many cases, for postpubertal patients, do egg banking. Sometimes we'll do embryo banking if someone has a sperm charming that they definitely want to have babies with in the future. We can also offer sometimes what's called a gonadotropin-releasing hormone agonist. This is a medication that kind of puts the patient in a medical menopause to really sort of maybe help kind of keep the ovaries quiet during chemotherapy so that maybe that chemotherapy won't do as much damage. It almost is sort of thinking about trying to keep the ovaries in like a prepubertal state. You know, we talked about they can take a little more chemo when they're prepubertal. We can sometimes offer fertility-sparing surgery. So if someone's having high-dose pelvic radiation, for example, we can do what's called an oophoropexy. We can take the ovaries and move them up and out of the field of radiation. And then once the radiation is complete, we can untack those ovaries and let them go back into place. We can also now do this with the uterus, which has been amazing. So this has really just sort of come out within the past couple of years, where we can have a gynecologic oncology surgeon actually move the uterus up and out of the field of radiation so that the patient can receive pelvic radiation and then they can put the uterus back. It definitely takes a very skilled surgeon to do this, but I think we're going to start to see many, many more patients utilize these options so that we can avoid the need for something like a gestational carrier or someone else to physically carry a pregnancy for that patient in the future. For our prepubertal patients, we're absolutely offering ovarian tissue freezing. This is where a whole ovary is removed, again, typically with another surgery that's already happening, a line placement or something along those lines, so that we can save that tissue, and we'll go into those details next. So an ovarian stimulation cycle, in order to freeze eggs or embryos, from start to finish takes about 2 weeks to do. It is not menstrual cycle dependent, so a patient can start at any point in a menstrual cycle. They start on what's called gonadotropins, so these are small injections. They're all subcutaneous injections that a patient takes, and they're on them for about sort of 10-ish, 11-ish days or so. These injections essentially tell the ovaries to grow multiple follicles at once. Remember back in that slide we talked about FSH just growing one follicle at a time? Gonadotropins are just extra FSH. So instead of growing one, we're hopefully growing a pool of follicles, maybe only 5, but maybe 10 or 15. And then during sort of this 2-week window, that patient's in our office every couple of days for early morning labs and ultrasound so we can ensure that they're responding appropriately to those medications. We start an ovulation blocker. It's called an antagonist, sort of mid-cycle. So it is 3 injections a day. And then eventually a patient takes a trigger shot. And this trigger shot essentially gets the egg inside the follicle ready for retrieval. And then what you see here, this picture, is what an egg retrieval is. So it's that transducer that's inserted vaginally. We can visualize the ovaries, and you actually can see the ultrasound picture in that bottom left corner. Each one of those like circles that you see there is a follicle. So they look like sort of black balloons on ultrasound scan. And then that very white line you see is the needle. So we just place a needle through the back wall of the vagina while the patient is totally sedated so they don't feel or remember any of this. That needle goes inside each follicle. We turn on suction. We pull out the fluid and the egg. An egg retrieval takes about 15-20 minutes. It's a very fast procedure, usually done right in an outpatient setting. You go home that same day. And then in the laboratory, what's happening is that we can take those eggs and we can either freeze them unfertilized, or I mentioned a sperm charming. If there is such that person involved, then we can take sperm from that person and we can inject the eggs directly. Those eggs then create what's called a zygote. That's a 2-day-old embryo. It's just literally 2 cells. And then we let that embryo grow into the laboratory until what's called a blastocyst. So this is a day 5, 6, or 7 embryo. Basically what you see with a blastocyst is an intercellular mass and an outer cellular mass. And if need be, we can even take cells from that outer cellular mass and send it for genetic testing. So if someone has a known genetic mutation, that can be screened for. What we're also looking for in many cases is just general chromosome numbers. So does this embryo have a normal number of chromosomes? And if so, then the patient will get all the information back about exactly what embryos are frozen for them and exactly what the genetic makeup is as well. We can also offer ovarian tissue freezing. And again, this is mostly done now in our prepubertal patients. We remove one entire ovary. It's typically a laparoscopic surgery. And we then isolate the outer edge of the ovary and we slice that into strips. These are called little cortical strips, and that's what we're freezing, are these little cortical strips of tissue. The hope is that in the future we can thaw those strips and actually sew them back into what looks like a quilt, and then we transplant that quilt of tissue back into the remaining ovary. And to date, there have been probably about 300 live births worldwide utilizing this technology. So the ovary recognizes its own tissue. The brain is still sending all those signals that it needs to send. The ovary, that little quilt of tissue, sort of wakes up, starts to grow and recruit follicles, ovulate out eggs, the fallopian tube takes it, and we've had quite a few natural conceptions utilizing ovarian tissue transplantation. There have been enough live births that American Society of Reproductive Medicine in 2019 now said ovarian tissue freezing is no longer experimental. So what that means is that in some states that have fertility preservation coverage, this is also now a covered service as part of the cancer care. So having that experimental label lifted makes a huge difference in insurance coverage. We certainly have patients for whom taking this tissue and transplanting it back might be contraindicated. And this is really more about my leukemia patients or my lymphoma patients who maybe have some sort of cells that are sort of hanging out in that ovarian tissue. Potentially we could reseed that patient with cancer. And so what we're working on now with a 3D printer is figuring out a way we can 3D print an ovary so that we can take essentially those follicles from that frozen tissue and then transfer them into this matrix that we've 3D printed, and then we can coax those follicles to grow outside the body. Still very experimental, not for use in humans yet, but we're getting there. And I would be remiss not to mention that while we focus on all these fertility preservation options, I think it is so important to talk about all the ways in which you build a family, right? It's not just always about your own gametes. That's important, and that should be an option that's offered and talked about. But I also think you should know that there are something called third-party reproduction, which is where you can get eggs from a donor or sperm from a donor. This is probably done way more in the United States than you would ever realize. But there are entire egg and sperm banks where you can get these gametes to then pursue family building. You can also use a gestational carrier. Sometimes it's called a surrogate, more commonly now called a gestational carrier or a GC. And that's just where you have someone else physically carry a pregnancy for you if carrying a pregnancy is going to put your health at risk or is not something that your physician team thinks will be a good idea. Adoption is another amazing way and another path to parenthood. I think one thing to note about adoption is that I've had some patients, so I've been doing this now for a long time, 16 years, and I've had some patients come back to me as they've been exploring adoption, and what they told me is that the adoption agency was discriminating against them because they're a cancer survivor, and the adoption agency is not really understanding what that means. And they're asking for that person to have their doctor provide letters saying they're cured and they're never going to relapse. I mean, all kinds of crazy things. So I think important to note, if you're looking at adoption, make sure you find an agency that's not going to be discriminatory. And if you need letters from your doctor, make sure to reach out to your team so that they can provide everything that you need specifically for that agency. I also put on here child-free living. And I think when I'm talking to patients, I'm sure to mention, like, I'm not telling you have to have kids. Like, that's not this at all. This is really just all about, like, giving you a choice so that if you wanted to pursue it, you knew that these options existed. But if you don't want to have kids, that is also a very valid option. So I think it's important. I know we all just kind of assume everyone wants to have kids, but that is not the case. So I think important to think about, if your child or if you're like, I don't really want to have kids, that is okay. When we look at survivorship and who's getting conversations about fertility in their survivorship clinic, sadly, we're finding that only about 50% of survivors are having fertility conversations. And we know that when you are given all the information you need to make the right decision, you're going to have less regret about the decisions that you made. So if you're in survivorship clinic and you're seeing your providers, I would really encourage you, if you've not had this discussion, to bring it up to them, to ask about your reproductive health if that's something that you're interested in, and then also ask to see a reproductive specialist. So this is just kind of a little bit of a pathway to sort of prepare you for that conversation. When you're talking to your survivor physician, APRN, PA, whoever that is, you can specifically ask for a referral from that person to a reproductive specialist. If they don't have someone that they typically work with, you may need to go back to that sort of ASRM website, that American Society of Reproductive Medicine, to find a reproductive endocrinologist or a reproductive urologist that's in your area that could see you. Your survivorship team may also offer some of this testing for you. So they may offer to do an AMH level or testosterone level. They certainly can order these labs for you so that you at least have a baseline and you can take that to the reproductive specialist. And then I would definitely have a care plan ready to go so that when you see that reproductive specialist, you have a list of, here's all the treatment that I've been through. Here is what I'm thinking about for my reproductive health. Here are the questions that I have. I find that if you have this care plan sort of set and ready to go, and this should be something your survivorship team can provide to you, it can really help you think about what questions you want to ask to ensure that that specific appointment is very productive and tailored to your needs. Doesn't have to be tailored to family building either, and I think that's important. It can certainly be tailored to your general reproductive health and feeling good. So if family building is not a goal at this time, definitely say that and be sure to say, I want to talk about my reproductive health, or I want to talk about hormone replacement therapy and how I can feel better. Those are all things that reproductive urologists and endocrinologists can offer. So barriers to care, and I'm going to speed through this because I have 5 minutes. We certainly know, and I obviously don't know every state that everyone's from here, but there are multiple barriers to accessing fertility and infertility care, and essentially cost across the board is one of the biggest barriers we know when patients from infertility to cancer survivorship to fertility preservation are able to access that care. This is just a list of typical costs associated with fertility cycles. So when they've sort of looked across the country and asked about pricing for IVF cycles, we're seeing that some of these cycles are in the upwards of 15 to 20,000 even, which is asinine. And then we think about health insurance, and like, normally I would cuss here and I won't, but holy cow, it's so confusing. Not a single system. We know that some of our insurances are regulated by state laws, some of them are regulated by federal policies, and we all get coverage in very, very different ways, whether that's through an employer, whether that's through the government, whether that's through the VA or TRICARE. This is sort of how health insurance is regulated in the United States. So the federal government regulates all the military plans, so that's TRICARE, which is active duty, VA health plans. They also regulate federal employees, and then they also regulate what are called self-funded plans. So you may have a policy that's, in the state of Illinois, but it's a self-funded policy, so that means it follows federal laws. State-based plans are more of our Medicaid, our state employees, more of our like fully insured large group plans. And the reason that this is important is because there are specific laws that regulate fertility preservation coverage, and they only apply in the state-based plans, not in the federal-based plans. And when we look across the board just at general infertility coverage as a whole, we found that pretty much a quarter of patients who were seeking infertility coverage across the United States actually had coverage, insurance coverage, for that service. The vast majority had 0% coverage when they were seeking their infertility. And because of that, that means they're paying fully out of pocket for these costs, which is asinine. When it comes to fertility preservation, we really hit home when we're talking to legislators that this is medically necessary. This isn't just some whim that someone wants. This is something that we are giving to someone. We're giving a treatment that we know is going to have a lasting impact on their fertility. Therefore, fertility preservation needs to be a covered service associated with that cancer care. So this is really how we're trying to hammer home to all of our state legislators how important fertility preservation, both pre-treatment and post-treatment, is for our cancer patients. And we've been trying to utilize the AMA's sort of definition of medically necessary and trying to really push for labeling fertility preservation as medically necessary, which they have done. Now we just really need to get the insurers to agree with that. We're also seeing that some employers, and if you get your insurance through an employer, they may have some type of this sort of fertility self-funded coverage through different fertility benefit managers like a Progeny, a Win Fertility, or a Carrot. A way that you can figure out if this applies to you is to simply check your employee benefit handbook. Largely you can find that online, and then I would just do a Control F for find the word fertility. And that should take you right to the fertility sections of your plan and policy so that you can know what type of coverage you have for fertility services. ASRM has also just recently evolved their definition of infertility, specifically to include that we no longer should have to wait for patients to be having timed intercourse to be labeled infertility. We should know that if we're giving treatment or a patient's been exposed to treatment that's going to render them infertile, that should count under that same definition of infertility, and therefore insurance, when they have infertility coverage, should be covering it. As we work state by state, we're kind of thinking of these two questions of when we're trying to pass a fertility preservation bill, do we add it as part of the cancer coverage, and that's sort of the route we mostly go, or should we try and amend the current infertility coverage to include fertility preservation within the states that have that type of coverage? And so this is just some general language we share with people as they're starting to really push for policy change within their own state to have access to fertility preservation coverage. And I think most importantly, this is a map of all the places that do have coverage for fertility preservation. So what I want you to do is find your state on that map. If it's green, It means in your state there is some type of fertility preservation coverage if you have a state-based plan. If it's blue, it means that right now in your legislator's office, they are working to get something through. So you would have an opportunity to provide your voice as a patient, as a parent, to help say why fertility preservation coverage is so important for other people in your state. If it's yellowy, that means that a legislator put forth a bill and it got knocked down. So I'm from Indiana originally. I'm really hoping one day Indiana will get some coverage. What I can tell you is a senator put forth some language for that. They didn't even look at it. They just shut it right down. So what needs to happen in Indiana is we need more patients to come forward and start pushing their individual legislators on a local level, if this is important to you, to say why this is important and why your legislator should back it. The Alliance for Fertility Preservation puts together these maps, and they are who really helps get these state laws passed. So if this gets you a little bit excited, please reach out to them. They're super, super lovely people. And they want to help get laws passed. So if you're interested in that, Alliance for Fertility Preservation is going to be your go-to. So we know that we need to improve equity, and in order to do that, we really need to work with all of our state legislators. We need to ensure that we don't allow for coverage limitations. There's one state in particular I can think of that just passed fertility preservation laws, which is great. But the legislators didn't want to pass embryo freezing as part of that, even though embryo freezing is a very well worked out option for fertility preservation, and it's something we've been doing for 40 years. But to one particular legislator, they felt like doing embryo freezing was against their own ethical purview, so no one in the state should get it. So we're really trying to push to ensure that all the language that's in these laws is broad so that everyone can access it. I have a lot of references. They're very boring. But most importantly, my email. So if you've got questions about anything, if you want to chat more, please feel free to reach out. Always happy to talk. And if there are any questions, super happy to answer them too. Thank you.
Go up and ask.
Have is based on a personal experience, and I think it'll apply to a lot of people in this room. My daughter was exposed to pretty significant amounts of chemo before we thought of, this was 25 years ago, we thought of preservation. And so we had her eggs frozen. We had a half a dozen that were able to be captured and frozen.
That's amazing. 25 years ago?
Yes.
Wow.
It was Dr. Morichellian helped set it up. Then the question came, because she had already been exposed, and this would probably apply to embryos, then we were thinking of, have they been damaged? And we were worried about birth defects. Mm-hmm. And so, is there any testing that's being done to answer that question? Are we now, if that child has been exposed to chemo, is there a increased risk of birth defects?
We don't think so. There are studies going on right now. But the egg itself seems to sort of protect itself from long-term DNA damage from chemotherapy. So if she was able to get those eggs out and get them frozen, what she could do in the future if she's ready is thaw the eggs, fertilize them to make an embryo, grow that embryo to the blastocyst stage, and then she can send out a biopsy from each embryo and have it undergo genetic testing. And that will give her back, does this embryo have a normal number of chromosomes?
What you just described, when did they start doing that?
PGTA, so it's called PGTA, it's pre-implementation genetic testing for aneuploidy. Aneuploidy meaning the genes are sort of not in the way that we would want them to be. That's probably been done for about the last decade.
Okay.
So it's a well worked out technology. Definitely ensure that, the person who froze her eggs, that's probably the clinic she'll want to return to have them thaw, because it's their thaw protocol. And then she could undergo all that additional testing there. So that's kind of one way to look at, is there an impact from the chemotherapy, right? That gives you some information.
Yes, yeah.
What I can tell you is, so at Northwestern, we do a lot of stimulation cycles in leukemia patients between chemo cycles. So a lot of leukemia patients show up in the hospital very, very sick. They have to start chemo right away. We let them get through their first cycle of chemo until they're a little more stable. We do an egg retrieval cycle, and then they go on to their next cycle of chemotherapy. And what we're doing right now is we're collecting follicular fluid from those cycles, and we're gonna look at all the different cellular markers within that follicular fluid compared to general infertility patients to see if maybe we can see different markers between those two groups, because that would potentially indicate this question that you're asking. Does the egg take on some DNA damage when it's been exposed to chemotherapy? Our hypothesis is no, but it needs to be tested. We can't test an egg itself for the genetics. When you test an egg, we would essentially kill it. So we can't just take an egg and test its genetics because it just has half the number of chromosomes. But really doing the full testing at the PGTA side is where that'll be helpful for her.
Thank you, doctor, for this important work you do.
Yeah, of course. I'm not a doctor, by the way. I'm a nothing, but yes. But I will take the honorary title.
Anyone else have any questions?
This isn't really well thought out, well formed.
I love it.
Thanks. What do we know about passing on cancer? And of course that takes many different forms, but neuroblastoma, like what do we know about passing it on?
Well, we really know if there is what's called a germline mutation that we can see, right? So this is where probably the more common ones that you've heard of are like BRCA1 or 2 or Li-Fraumeni. There are very specific germline mutations that we're starting to see that when someone has that particular mutation, they're more likely to get cancer in their lifetime. So using that same technology, that PGTA, if we know that someone has a mutation, we can actually send that mutation to a genetics company and they'll create an assay on that mutation. And so then when someone has embryos that they biopsy, they can actually run that particular assay against those embryos and they can tell you which embryos then carry that same germline mutation. This only applies though to germline mutations. So sometimes we're doing tumor testing, right, where we're looking at mutations within tumors themselves. That doesn't mean though that that particular mutation is in the germline itself, if that makes sense. That's really just in the tumor itself, so that's not something that would be then passed on. It's only if it's within your own sort of genetic chromosomes that you're then passing on to offspring. If you're a carrier for that mutation, then you can typically have about a 50% chance, if it's dominant, of passing that on. We can also look at recessive mutations that we know. There are lots of panels that can be done. These are not cancer specific. These are more things like spinal muscular atrophy and cystic fibrosis, and this is sort of a general panel that can be drawn prior to someone getting ready to build a family so that you can find out if you're a carrier for that, and if you're a carrier for that and your partner or the sperm choice that you're using is also a carrier, then you have a 25% chance of passing that on directly. But again, could be looked at through that genetic mutation testing, where we're looking specifically at those particular mutations and then also sort of the general chromosome makeup of the embryos. Does that answer your question? Yeah, okay. All right, of course.
Anyone else? Okay, all right. Thank you, Kristen.
Thank you.
I miss your swearing, though. Oh, good girl, good girl. Our next speaker is Dr. Mark Applebaum. He's an associate program director at the Physician Scientist Development Program in the Department of Pediatrics at the University of Chicago, as well as many other titles held there. He received his MD at Northwestern here in Chicago, and his residency at UCSF in San Francisco, and his fellowship in pediatric hemonc in the committee, and he's on the committee on clinical pharmacology and pharmacogenetic. Oh God, forget it. It's been a long day at the you say it.
I can do all that. It's fine.
He has authored many articles and co-authored numerous articles and research projects. He's involved in clinical trials that are ongoing and invited as a guest speaker at many professional groups. And his talk today, we thought we'd do a little bit on AI. So his talk today is going to be rapid histologic classification of neuroblastoma with AI.
All right. Thank you, Pat, and thank you for that really kind introduction. Cool. So this is, I think, my third time talking to you at this conference. It's nice to be back. I am a pediatric oncologist, is really the short version of that introduction. I spend some of my time taking care of our solid tumor patients and our neuroblastoma patients nearby at the University of Chicago, and I also run a lab. And what we're really interested, or two parts of our lab. One is drug discovery and therapeutic development, and also biomarkers. And today I'm really going to be talking more about the biomarker end of our lab. This idea has come up already. I think Carrie gave a nice overview of that, Dr. Shebby, and talking about how can we use MIBG scans and Curie scoring to think about who's going to respond and who's not. Those are a lot of the kinds of questions that we like to ask with these sorts of the data that I'm going to show you in just a second. No disclosures. So what is AI? I mean, this is a talk that's, I've been giving variants for a little bit of time now, and I always have to do the introduction differently now, because I think most people have worked with AI now, right? Most of you, if you've done, let's say, an internet search, you've probably seen some AI-generated clues and some questions. But I really want to talk just briefly about how I think of AI as a researcher and an investigator and a doctor, and what I think about it in terms of how it can be used in very specific contexts. So I'm going to talk about it in a little different way probably than you're maybe thinking about with your search engines and Siri and things like that. So AI is a type of machine learning. Machine learning models can be very broad. Artificial neural networks are a part of that, and deep learning networks, which is really what AI, as we think about it a lot today, is really part of. And really, it's just math. It's really just a lot of math done a lot at once. And it's a way to take text or audio inputs, video, and make predictions. So really, the way I think about it, AI, is it's a prediction engine. When in ChatGPT, it's predicting based on all the English language that it's read. It's predicting what your sentence is going to be, how you want it to be structured. It's not actually thinking. It doesn't really understand what it's saying. But it's making predictions about how data are related to each other. And what's the basic form of these predictions? Well, I'm going to take you back to high school algebra, or maybe middle school algebra, and talk about y equals mx plus b. Right? What is a correlation curve? If you have a bunch of data, you can say what's the intercept, what's the slope, and how are these data related to each other? Are they positively correlated? Are they negatively correlated? And how strong is that association? And you can draw a line to that, and you can sort of describe your data that way. And then really what I think about AI is a way to do that at scale. So instead of doing one correlation at a time, you're doing millions, billions, trillions, even more correlations at one time, to really say how is something associated with something else. And a lot of times you'll see neural nets and AI sort of models depicted in these sorts of line plots, which is saying how do I take bits and pieces of data, say are they positively or negative correlated, how can I mush that together, make some more correlations, and ultimately come up with y here, go from x and get to y, which is really the prediction that it's trying to make. In more human terms, let's say I want to have an AI model tell me what is a cat, or like identify pictures of cats. Well, I would give it a lot of pictures of cats, and that model would break that cat down into its component parts. It would take the picture and that you see on the bottom, and it would say, I've got some lines, I've got some curves, I've got some really dark shaded spots, and break them apart, and then try to put it together in all sorts of different ways to say what actually models the thing that I was given. And then it can come up with, okay, if I put these lines together in this way, I get an eye. If I put them together another way, I get a nose, et cetera. And then take all those parts and put them back together and ultimately say, this forms a cat, right? So it's really just how do I put these pieces together in not infinite, but many, many more ways than we can generally calculate to make a prediction. And one of the things we think a lot about in medical AI is really the trustworthiness of what you're getting. Hopefully, when you've interacted with ChatGPT or Claude or Google, you're thinking about what are the sources of data that it's using, and is this reliable? Is this a hallucination? I won't get into too much of that today, but we really want to make sure, especially if we're going to use it in a medical context, that we understand it, we know what it's doing, and we believe that what it's saying is real. So this is a classic example. This was from a Google study that was published a while ago where they said, let's take huskies, family pets, and compare them to wolves. And can we have an AI model spot the difference between huskies and wolves? And it turned out that they could really do that. And then when they went to say, well, what features was it looking at? Was it looking at the size of the ears? Was it looking at the shape of the eyes? And it had the model say, well, what did you use to make your prediction? Turns out the answer was snow and background. Because the thing I like to remember is AI is lazy. AI will do whatever it can to make the most accurate predictions most of the time while using the least amount of information. And most people, when they take pictures of their dogs, their pets, are in their house, maybe on a couch, maybe in their backyard, not necessarily in a forest in winter. That's probably less common. But if you're taking a picture of a wolf, you're much less likely to be taking a picture of that wolf in your house, I hope. And so that outdoor background actually became what was really good differentiator, which most of the time when I presented this, will say, actually, well, that's not really great for telling A plus B. Although when I've talked to some tumor microenvironment folks, they say, well, look, it's not the tumor that matters, it's the background, it's the stuff that it's in. So different ways to think about the same kind of data, I guess. And so one of the things we think about a lot with AI in medicine is how can we use this for clinical decision support? I am not one, I hope that AI is going to replace doctors. I'd like to have my job. But I think it can help. And I think there are ways that it can help us do things better, faster, and more consistently. And it can use all sorts of data. So I don't think anyone's really talked about this. This is Meredith Irwin's talk. I'm sure she's going to be presenting this tomorrow. Just talking about risk stratifying in neuroblastoma. I won't get into that because I don't want to steal anyone else's thunder. But I think many of the people in this audience know that if you have a child with high-risk neuroblastoma, they don't do as well. And if you risk stratify it as high risk, we don't really have a great way to say, is this person going to respond or not? Is this person, is this child going to do well or not with any given therapy? Sort of like what Dr. Stryber was talking about earlier with MIBG scans. We've tried a lot of prognostic markers in neuroblastoma. As I think many of you know, the things we use in the clinic, age, stage, MIC-N status, ploidy, histology, those are important. Those help us risk stratify. We've known about those for a long, long time. MIC-N was described by Garrett Berdour in early 1980s. But we know today that we have a lot of other kinds of information that we have from our patients, whether that's copy number, whether that's expression arrays, whether that's epigenetics, cell-free DNA, mutation analysis. We have a lot of information. And we also have some rich clinical information, right? We have patient charts, we have slides, we have scans. We don't really use a lot of that, and I think we can do better. And so one of the things that actually recently came out is there's a lot of companies and investigators who are trying to take digital pathology, right? So all children, when they're diagnosed with neuroblastoma, had a biopsy. That biopsy was looked at by a pathologist who talked about the histologic criteria that said this is unfavorable versus favorable histology, and I'll go over that in a minute. And then, we use that as part of our risk stratification on our treatment decisions. Well, now in breast cancer, there's an FDA-approved tool where you can take a slide from breast cancer biopsy, run it through an AI-powered analysis, and it will tell you this is a low-risk sample. This is, you might be able to avoid chemotherapy based on the risk that I'm seeing. Here are some other factors, that it can identify. And it also, I think if you look on the bottom left, tell you how confident it is in that prediction, right? Again, this is a prediction model. So it's important for clinicians to really understand how confident is that AI model in saying this is how you should act on this disease. One of the things we're trying to think about is how do we bring this to neuroblastoma, right? How can we take things like slides or things like images or the clinical data and put them together into a predictive model to say, somebody has high-risk disease, and maybe even give some ideas about treatment, right? This tumor might be sensitive to chemoantibody, avoid transplant, right? That would be amazing, right, if we had that tool. I'm not saying we do, but, right, that would be nice as a biomarker, right? That's the goal. And so we think about high-risk neuroblastoma treatment. Again, this is something I won't belabor. We get the biopsy at the beginning, we get the MIBG scan, we go through chemo. As Dr. Strebe already talked about, we know end of induction response is important, but we don't really use that information at diagnosis to try to make predictions. And so what she talked about and what I'll talk about first is a little bit of the work we've done with MIBG scans. So you already heard about MIBG scans, you know about Curie scoring, so I don't have to go through this. You've already seen this curve already, and you've already heard that just counting dots didn't really help as a biomarker, at least at diagnosis. And I know there's ongoing efforts, and I hope they're successful. But I think one of the challenges with using, say, an MIBG scan is that there's actually not a lot of biology under that. And so it's a difficult modality, but I think there's value in that. And what we said was, well, maybe instead of counting spots, maybe we could run this through an AI model. And so we had a hypothesis that this was an earlier version. This was something we started with 7-8 years ago at this point. Could we put these MIBG scans through an AI model to predict response to induction therapy? And can we use that to try to better sort out those patients with high-risk disease when they're diagnosed? And this was published a few years back now. And we took these planar MIBG scans as a first pass. They're the easiest data to work with. And we put the AI model on, and what you're seeing here is the color where the AI model paid attention. So things in red where the model said, here's disease that I need to pay attention to, which was actually really nice that the model found disease and wasn't using just noise or snow or background. And we showed that it had some prognostic value. An AUC, an area under the curve, is a predictive marker of how well something was predictive. 0.5 is a coin flip. 1 is a perfect predictor, and -1 is a perfect anti-correlation. But when we added the CNN, that's the AI model, the convolutional neural net, when we added that to the clinical model, and you see that bottom line, the geometric mean, we got something that was a little bit better than a coin flip. So there was value in both the clinical and the MIBG for predicting, to some extent, who in these high-risk trials were likely to respond to induction therapy or not. Switching gears, and that is ongoing work, and we've actually gotten a lot more of the scans that Dr. Strebe is also working on as well, and so that work continues. But what I really want to switch to now is actually just focusing on the histology. Because there's a lot of information there that we don't use as well as we could. So for histology, as a refresher, Dr. Hiroshimada, who is the COG Central Review, came up with first the Shimada classification system, which eventually got converted into the International Neuroblastoma Pathologic Classification System. So this is how pathologists report out what they see under the microscope. And it uses age, your diagnostic category, which is neuroblastoma or ganglioneuroma, some of the features that are defined under the microscope. Grade of differentiation, does it look like it's turning into a nerve-type cell, which we know has less metastatic potential, or does it look like one of those small round blue cells? And the mitosis characteris index, which is essentially a marker of cell division. And they developed a score, the INPC, which takes all these 4 criteria and mixes and matches them to define somebody as having favorable or unfavorable histology. So ultimately, you get to this favorable, unfavorable, and what's been published as well, again, this was from Meredith's paper, but this came from Hero, is that if you have favorable biology, not surprisingly, those patients have much better outcomes than if you have unfavorable biology. So we know that this is important. And so we again said, well, we can use AI and deep learning methods to identify these complex histologic patterns. We know there's some data from the COG that a local pathologist will differ from our central view about 20% of the time. They concur about 80% of the time, but 20% of the time, pathologists will disagree. About 10% of the time, it will really matter in terms of how we risk stratify someone. And so All slides that come to the COG through COG trials actually go back out to Dr. Shimada for sort of gold standard pathology. And one of the things we're trying to think about is how do we sort of spread that? How do we not be so reliant on central review and help local pathologists make more accurate diagnoses? And so we thought we could use AI to do this, and this was actually a Pritzker medical student at the University of Chicago, Sid Ramesh. He's now a second-year resident in internal medicine at U of C. He was helping with this part of the project, and we took slides that we had from our institution, we took slides from the COG that we were able to obtain, and also worked with some collaborators at Lurie Children's to look at sort of a large panel of different kinds of patients with neuroblastoma. We also were able to say, what is their MIC-N status? So not just looking at the histology, but could we actually think about, can we use the AI to say, is this a tumor from a MIC amplified tumor or not, right? Can we actually get some of the genomics off of just the slide? And I won't go through this in detail, but this is for any AI aficionados in the room. This is sort of how it works. Because neuroblastoma is a rare disease, what's nice is that you can actually train AI on slides. And there's public databases now of like 1.5 million slides, just histology slides, normal, tumor, cancer, et cetera, that you can teach AI like to sort of be a pathologist and so identify like what is a slide, what is tumor, what is normal, what is noise, and use that to then train specifically on our neuroblastoma sample. So we can basically what's called transfer learning and take this model that's been generated on these millions of slides and use that to pre-train models and then say, let's learn things about neuroblastoma. And this is done in a company they spun out called SlyFlow that actually my former trainee is now, I think, one of the medical directors of that company. And so here's a couple of examples. This is from our, that same paper that we published. There's a neuroblastoma on the left and a ganglion neuroblastoma on the right, so more aggressive small round blue cells on the left, more localized. These are going to be our low-risk patients on the right with ganglion neuroblastoma. And it's hard to tell from this picture, but I hope you can kind of see there's a little bit of a blue outline on that bottom part and on the right. That's actually the AI saying, where is tumor? So it automatically can actually segment and say, here's the tumor, here's normal, and it does a really nice job of that and gets rid of all that sort of pink stroma and just sort of normal tissue surrounding the tumor cells. And then we can say, well, also show us if you're building a model, what's important to you? And so at this tile level window, we can use tools to basically say, what did the model think was important? What part of that tissue, what part of that slide, what part of that tumor was actually important for it to make a prediction of something like grade of differentiation or MKI or MIC-N? And so we published that, only using 100 or so slides, which is not a lot. So if anyone's familiar with, AI and big data, it's big data. This is very small data, but we're getting good numbers, at least at first pass. So this was published now a year or two ago, where we were able to find, with an accuracy of about 92, 94%, we could get diagnostic category, neuroblastoma or ganglioneuroma. Grade and MKI were a little trickier, but even with a 77% accuracy to say, this is MIC-N amplified or not, just from the slides. And it was using relevant features and different features, right? So if you looked at what was the model using for MIC-N amplification versus diagnosis, different features of that slide and of that tumor actually mattered to the AI model. And those things are on the right are sort of junk parts of the slides, and it actually paid very low attention to that junk. So this part is unpublished data, so for those of you taking pictures, please do not post this, share this. We're planning on submitting this soon, but I wanted to give you a taste of what's to come. So this is actually, we took those data and we went back to the Children's Oncology Group, and they gave us another 1,500 slides. We've actually got promises, hopefully, to get another several hundred slides, and did essentially the same thing, and we're getting really nicely robust data. So these are, as you know, Children's Oncology Group slides from across the country, North America, Canada, from all sorts of patients with all sorts of disease, and we're able to say favorable or unfavorable histology in this very rough preliminary way. And again, I want to say this is preliminary, unpublished, and not entirely validated. over 90% of the time we're getting this right, which is pretty darn good, especially considering that your average pathologist gets it right about 80% of the time. And MIC-N, we're up to about 90% as well, saying if a tumor is MIC-N amplified or not, just based on the slide. Again, very early, very preliminary, nothing to say we're going to use in the near future. But our hope is that this will go to the COG soon and hopefully be integrated in some pilot studies and things like that. I want to highlight this just briefly. So we applied for funding from Cancer Research UK. If anyone here knows anybody there, please tell them to fund us. But as part of that grant, so it's my first time writing a European grant. They have or grant for a European funding agency. They have a very robust requirement for patient advocacy and patient involvement. And I was actually really proud of how we put this together. So we actually had 2 leads, one from each side of the pond. So this is a joint University of Chicago, England project. And we had, as you can see, I think a fairly robust engagement from patient advocates, parents, and actually a survivor of neuroblastoma to give input on this project. And I think this was actually really rewarding for me. Normally, as an investigator, this is a hard part because we don't, I want to go do my science, all right? I just want to do what I want to do. But I think this is a really great way, one, for the patients and the advocates and for people like you in the room to have a voice and to help us think about like what's important. And I think it's also really helpful for me to say to the funding agencies, this matters, right? This is research that people who are dealing with this care about. So I really encourage you, as much as you're able, to get involved and to be active and to find your local local oncologist and say, how can I get involved? I think this was just a really great experience, and I just, whether we get funded or not, wanted to highlight how much I've actually enjoyed working with our patient advocates on this project. Some of the other sort of tricks we can do that I think are just kind of for show at this point, and I don't really have data to say yet, we can also create synthetic histology, so we can actually have the AI say, well, what are the important features of high-risk disease versus non-high-risk disease, or MIC-N amplified versus not, and actually create synthetic histology to say, well, what does that look like? So we can actually understand what are the features. And this has been published by one of my AI collaborators, Dr. Pearson, who's done a lot of this work. This is looking at thyroid cancer. So there's 2 different kinds of molecular thyroid cancers, a RAS-like and a BRAF-like. And they can use the trained AI model to identify one versus the other and say, well, if you go along the gradient from left to right, on the left is really more BRAF-like, on the right is more RAS-like. And they actually use these models to train human pathologists. So they actually used the synthetic histology and said, well, this is what we typically found in a RAS-like tumor or BRAF tumor, and showed that when they gave that to pathology residents, they did better. So this is actually a good way also to train pathologists in how to interpret rare diseases like neuroblastoma. This is, again, probably never going to get published because I don't think it worked very well, but I just wanted to give you kind of a flavor. Like, we can say, like, what's a more mesenchymal or adrenergic tumor, and have it, have the GAN, the adversarial network, tell us, like, what might that look like under the microscope. I'm not going to try to interpret this for you. I'm not going to try to make any sense of it. And again, I think it was just sort of an interesting sort of first pass and tool, but I just wanted to give you a sense of the kinds of things we're thinking about. So then really, like, how do we actually bring this to the clinic, right? That's actually, I think, what most people in this room care about. We're thinking about this not only through COG, which I alluded to, and talking with the Biopath Center and the Neuroblastoma committees, et cetera. But we're also thinking about how do we establish this worldwide, right? Because once you have the models in place, it's actually fairly easy to run them, as I think most of you are familiar with your experiences with AI. And actually, one of my collaborators, named by Dr. Pearson, built a microscope. So the microscope we use at Comer and they use in Ohio and other places generally costs tens of thousands, if not hundreds of thousands of dollars to create really nice pixel-perfect images. Dr. Pearson actually made a microscope for like $400 or $500 and deployed that in various parts of Africa. And as you can see in this correlation plot, whether they use the $400 microscope or the $40,000 microscope, got really good data either way. So this is actually something that's scalable, and you don't necessarily need the perfect camera, the fanciest camera everywhere. And he's also working with people in Africa, in hospitals, and this is Kenya, How can we bring this across the world? So I think this really gives us opportunities to not just build something here in the US, but actually share what we're learning around the world and hopefully make things better for all kids with neuroblastoma, not just the ones in highly resourced countries. So in conclusion, I think I've shown you that there are very specific and I think very interesting use cases for AI in neuroblastoma. And my colleague, Dr. Volchenbaum, I think is going to give you a higher level overview with different kinds of data a little bit later, but hopefully this will be a good primer for that. It's something that we're very interested in the COG, and there's a lot of talk about how do we implement these sorts of models in our clinical trials and in the clinic. And I think the next frontier that we're also thinking about is multimodal, right? How do we bring together the slides, the path reports, the imaging, the MIBG scans, the CT scans, the SPECT, with all the genomics that we're robustly generating, and make sort of the best predictors, right? Can we actually use that to figure out who are those kids who really need the whole kitchen sink, who might need chemoimmuno, who might need something totally different? So that's the dream. A lot of work to do to get there, but that's what we're aspiring to. Just want to thank patients' families, right? You guys make all of this possible by taking part in studies and participating. Members of my lab, collaborators, all the funders. Happy to take any questions. And I hope I stayed on time. Clear as mud. Cool.
Does anyone have any questions? My apologies.
Nina, go for it.
This is super exciting and breaks my mind because I don't understand how AI works that well yet, but we will hopefully all get there. Two questions. One, does the AI model tell you why it tells you this must be McM amplified based on the imaging versus this is not McM amplified? Is there something that we can actually learn from that predictive model?
Yeah, no, that's a great question. And so that's essentially what this is going after, right? So this is areas where, if I showed you those heat maps before, right? So this part, so the bright yellow parts are the sort of, well, the chart that doesn't project as well, but say like there-ish in the middle. That's a part that the AI thought was really important for making a decision. And we can zoom in on that individual tile to say, what was that? So thank you for asking me to clarify that. And that's what these are. So these are those individual tiles that the AI said was important for making our prediction. And so you can see different kinds of histopathologic features that are associated with the diagnostic criteria, the MKI criteria, and MYC-N, which is a lot of small brown blue cells, which might kind of make sense if you're thinking about more adrenergic like MYC-N amplified cell. What I think this will get really interesting is when we go towards sort of more outcome prediction and say, not just looking at what we already know about histology, but what can we find that's new that actually predicts outcomes that we're not already picking up in the histology? And I think that'll be really interesting to dissect and see where the AI is picking up.
Right, like MYC-N, yes, high MKI, highly proliferative, very aggressive, but what are other high-risk markers? Can the AI model also pick those up, or do they look the same? Right?
Yeah, so we're going to try to look for all those sorts of nuances in there.
And then did you train your model against other tumors, especially when you're thinking about, taking this into like other countries, other communities? Like, did you train this also in like other blue round cell tumors?
Yeah, no, that's a great question, and there are groups around the country working on that. I know Andy Huang and the renal tumor group in COG are looking at that. There's its own sort of issues there because there's a lot of interesting heterogeneity. There's a lot of people who are interested in doing this within COG. There's actually going to be a discussion at FELCOG through the ITSC to talk about how do we move forward with some of these kinds of projects. But I think that is another frontier, which is how do we make sort of an agnostic model that'll tell you, not just what kind of neuroblastoma, but differentiate neuroblastoma from anything else.
Right, because I think, when you're thinking about can this help other pathologists who haven't seen that many neuroblastomas versus other blue round cell tumors or lymphoma or whatever, can such a model actually help them in like a couple of years?
Yeah, no, make the basic diagnosis, and I think you're right, and that'll take a lot of cooperation between a lot of people to mush slides together and do it. It's a doable task. We're just starting to build the disease-specific data set, so once those are up and running, absolutely, right? We can combine all those diseases and make that kind of a model.
Wonderful. Thank you.
All right.
No one else has a question? Well, you can hit up Mark. Oh, one more.
right.
We got one more. Go
I
ahead.
know I'm also before lunch, that's all,
Sorry, I just had a quick question. What are your thoughts on like AI getting introduced into clinical regulatory kind of pathways and stuff? I just know that it's hard in my work. We have a really hard time figuring out how to get it, physicians to trust what that confidence score that you mentioned. So I don't know how you feel about it or how you're trying to overcome those fears.
Yeah, no, I mean, I think regulatory issues are super important in thinking about what is going to be acceptable. And I think that's where a lot of the explainability features come in that we're thinking of, and having gold standard and using not necessarily cutting edge models, but sort of more established models on rare disease, which I think are, if we used an established pathway, you can do something in a rare disease and a novel thing without having to explain your methods as much. And then I think, also having SlideFlow as a commercial partner, they're much more interested in regulatory than I am, right? Their job is to get this through FDA, not just for neuroblastoma, but they're obviously also working in breast cancer and lung cancer and all the other adult diseases. And so, but there's a pathway, right? There are no FDA-approved tools. And I think with the explainability and having the right gold standards, I think the FDA is open to that.
Anyone else? Okay. Thank you, Dr. Applebaum.
Thank you all.
Thank you. We can take a break here for lunch. If you have kids in the kids' room, you can go ahead and get them. I believe they're pretty well set up for lunch next door. So go ahead and grab some lunch, and we'll be back at about 1:30. all set. We're going to go ahead and get started, and unfortunately, I forgot to do Dr. Nina's introduction, so she's going to do her own. So, Dr. Nina Weichert-Lee.
You got the name right. That's half the credit already. All right. I go by Dr. Nina usually. Yep, right there. I'm a physician scientist. I work at Boston Children's in Dana-Farber. And when Pat emailed me and invited to come to this conference, I was very humbled. And I have to admit, I'm a little nervous to give this presentation about my work in front of all of you. Because your children are really the driver of what brings me to the lab every day. I initially trained in Germany, so this is where my little accent comes from, and then moved to Boston and did a second pediatric residency training at Boston Children's, and then a fellowship in pediatric hematology and oncology at Dana-Farber. And I've been an instructor since 2022, and I work mainly on neuroblastoma. There are some other solid tumors that I'm also interested in, but it's mainly really neuroblastoma, and I focus on the epigenome. So the epigenome is this big umbrella that helps our cells, our healthy cells and cancer cells, to package DNA. And before I start my presentation, I try to quickly illustrate what the epigenome does. So I always think about our DNA as a spaghetti. I hope I don't ruin lunch or dinner plans for anybody. But it's like this long string of genetic information, and that needs to be packaged into the nucleus, so really to fit into our cells. And the epigenome is like the big umbrella that helps to package it. Like think about your fork twisting up the spaghetti. So the epigenome is like the fork that helps to twist it up or twist it open to make it accessible or even to close it. So let me show you how I got to that interest in neuroblastoma. Okay, perfect, it's working. So neuroblastoma is a tumor that develops from the embryonal neurocrest cells that fail to develop into those normal peripheral sympathetic neurons. And that normal development is pretty complex, so I made a very simplified illustration here that you guys can see. It's a very complex steps with several control centers that control the really highly controlled environment, how these cells are supposed to differentiate. And if in any of those steps things go wrong, neuroblastoma can arise. As you are also very familiar with, this is the outline of the standard of care COG treatment scheme with induction chemotherapy, consolidation treatment, and then post-consolidation treatment. And during my training as a fellow, I became particularly interested in this post-consolidation treatment. And the reason is that one of my attendings worked clinically on cis-RA. And cis-RA, also known as ATRA or isotretinoin, there's so many names for it. I'll stick with cis-RA. Sometimes I say a different word for it, but I try to be consistent. So cis-RA, which is pretty much like a vitamin A, and is important for the normal development of neural crest cells. So even in normal development of those neural crest cells into the peripheral sympathetic neurons, the body makes endogenous vitamin A that those cells then forced to differentiate. And we use it as a clinical agent to force neuroblastoma cells into the differentiated cell state. And you probably have seen these survival curves from clinical trials from the 1990s, where we have shown that cis-RA treatment can improve the overall survival when it's combined with the autologous stem cell transplant. And then longer follow-up studies, 10 years later, they raised concerns that yes, it can prolong survival, but it may actually not prevent relapse. When we looked in the lab, what retinoic acid does on a molecular level, we and others found that it actually helps to turn genes on and off. So it helps to make more of one gene or like to prevent the other gene from being turned on and off. And it does that by going into the cell nucleus and binding to its receptor that sits right there on the DNA. And with that, it then stops cells from growing and promotes cells to differentiate. Unfortunately, similar to what we see in clinical trials in the lab, we also saw that this is a transient effect. So that means when we treat cells in the lab in a petri dish in plastic with retinoic acid, with cis-RA, those cells slowly stop growing, they look differentiated. That's the orange line in my graph here. And I did that for 14 days, and then I stopped the treatment, and you can see those cells like proliferate and grow again. And those little images should reflect that too, that we can induce differentiation. That's here, this little star cell that looks like a neuron, but that is also reversible. So when I came out of fellowship, I was like, well, retinoic acid, cis-RA, seems like a great drug if it would just work better. Right. So I was very ambitious back then, and I was like, well, when it goes to the nucleus and binds to a receptor and turns on genes that induce this differentiation and stops the cell from growing, what if we can just like knock it in and like block it from being reversible? And that's where the umbrella comes in, the epigenome, right? Like, what if we can just knock it in so it can't like be reversible? Maybe we need something in the epigenome that can like make this more durable. And in the lab, we test these kind of hypotheses with screens. So those are big experiments that need either a computer, a machine, or like a really busy technician. I was lucky to have a really good technician that helped me with this. So we had 452 epigenetic inhibitors. We call this a library. And we took neuroblastoma cells in the plastic, and we treated those cells either only with one of the 452 epigenetic inhibitors or together with the cis-RA. And then we let them grow or not grow for a week, and then we measured how much they grew. And a lot of compounds really didn't touch the cell, but there were several hundred compounds that slowed down growth, but only 28 compounds that really worked together with the cis-RA, that made the cis-RA in the screen work better. And one of them was a compound that's called PF9363. And when I first got these results, I was super excited because that was a relatively new compound a couple of years ago. So what is that? PF9363, the name says it already, is a compound from Pfizer, that's the PF. It inhibits two enzymes. Those are called KAT6A and KAT6B. Those two enzymes make modifications to the epigenome. So those are histone acetyltransferases. They make little flags on histones. The histones are pretty much like part of the fork, when we go back to my spaghetti comparison earlier. So the histones are part of the fork, and when they get little flags, you can either open up the spaghetti twist or you can close it even further. And when you inhibit those two enzymes, you can make the spaghetti fork ball a little tighter, so it's not accessible. So the idea is that you turn off genes. And over the last 3-4 years, this compound has become more popular. There are other people, especially in adult malignancies, working on this. There are several studies in breast cancers that showed when you treat cells in the petri dish in plastic, it slows down growth, or in leukemia and AML or in lymphoma. Pfizer now also has moved on and developed a clinical compound that's analog to the one that I found in my screen, and they initially did studies in patients with breast cancer to test the safety of the compound, and they found it was relatively safe at a certain dose, so they now moved on to a phase 2. We found actually it has some anti-tumor activity in patients with certain types of breast cancer, and now they're moving to a phase 3, which will become important to us in a little bit. So after the screen, I went back into the lab, and these graphs look busy, but what we pretty much found is that in orange you see the retinoid, and in black there's my control. Yes, the retinoid suppresses growth. The blue is just the KAT6 inhibitor alone. It does a little modest effect. But then in red, that is the combination. We found that it's actually synergistic. So they work surprisingly really well together. I also looked on a single cell level. That means like we don't only look at the big group, we actually look at each individual cell in the plastic flask. And we found when we treat neuroblastoma cells with the retinoid, actually only 50% of the cells respond to it. And I think that is like the concern, or reflects some of the concerns that we have seen clinically and in other studies. And when we combine it with the KAT6 inhibitor, with that new compound, we can increase the response to 75%. And more importantly, we can also kill the multipotent cells. So those are the cells that love to proliferate and make new baby cells. So we were really encouraged by these in vitro studies that we did in the lab on the cell lines. This is how the cells actually look. I think I wanted to show them because I think it really shows nicely what differentiation actually means. So you see in the first column, those are the parental cells. Those are like the normal looking cells. And then the second column shows how they differentiate a little bit with the cis-RA. And then in the last column, you really see how the cells differentiate in these neuron-looking cells. They make these long axons go from one cell to the other cell. So I think everybody hopefully can appreciate what differentiation means. So then the next question that I asked myself is, well, this is great. We can make retinoic acid work stronger, but is it actually more durable? So what happens when we stop the treatment with the retinoid? And I will show you some work that we did in cell culture, but also some work that we did with animals. So this is a busy slide. I want you just to pretty much focus on those growth curves where we measure cell growth over time here, like over the course of 28 days. And in orange, again, you can see this is the growth curve for cells treated with the cis-RA. And then day 14, I stopped the treatment. And then in black, you see how they then behave. They behave very similar to the control and just like strongly proliferate. This is the epigenetic inhibitor, the KAT6 inhibitor by itself. Didn't have a lot of effect in cell lines. After like 3 to 4 weeks, the cells seem to be bothered by it and are slowing growth significantly down. And then in red, you can see the combination. So in red, I treated the cells for 14 days with both the cis-RA and the KAT6 inhibitor. And then on day 14, I stopped the cis-RA and only continued the KAT6 inhibitor. So you can really nicely see that we can make the growth suppression that we induce with cis-RA, we can make this longer if we put on top this KAT6 inhibitor in cell lines. So let's look what this looks like in mice. So again, these are our model systems that we have. I acknowledge that they're not patients and they're not optimal. They all have their flaws, but I take them as a starting point for testing some of the drugs that I'm interested in. So we took this immunocompromised mouse and injected the human cell lines into the flank. That's a pretty standard model. And then we treat the mice with the drugs. And in black, you can see pretty much just a vehicle control carrier. You can see those tumors proliferate over time. That's like a volume curve that you can see here. And then in orange, again, the cis-RA, which seems to be really nicely effective in this mouse model as long as you give the cis-RA. And I think this mouse experiment really was so frustrating to me to see this so beautifully that this is really only a transient benefit. So I then went back and treated the mice with the new compound, the KAT6 inhibitor, at the dose that Pfizer had recommended to us. We were very surprised to see how effectively it suppressed tumor growth. As long as you give it. When you stop treating the mice, tumors also start to proliferate. And now here again in red is the combination, so 2 weeks together, the cisRA plus the new compound, the KAT6 inhibitor. Then on day 14, I stopped the cisRA and only continued the KAT6 inhibitor. We were super pleased to see that this really suppressed growth. All right, so this is the first summary that we think we found a new compound, this KAT6 inhibitor, that seems to synergistically suppress growth together with cisRA, both in vitro and in our in vivo models. And then I put my physician hat back on and asked myself, well, if this new compound would ever make it into the clinic, where could this find a place? And obviously, the first thing that came to my mind, because cisRA is post-consolidation, well, what if it were like a post-consolidation treatment or something like that? And as you all know, post-consolidation therapy includes alternating dinutuximab, antibody against GD2, plus cisRA. We also know not all the tumors express GD2. I think there's still lots to be discussed and to be discovered of like what are actually the percentages of tumors that express GD2 on the cell surface. We certainly know that there are some small amount of tumors that don't express GD2, and we also know that some tumors lose GD2, especially after patients have received immunotherapy with dinutuximab. So I wondered, well, before I even think about introducing a new agent, what would this KAT6 inhibitor do to GD2 expression? So we went back to the lab, and this is a flow cytometry experiment that I show here. So where we measure the cell surface amount of GD2. And then in black, you see in these 3 cell lines that I've used for most of my work in the lab, actually do not express high levels of GD2. I don't know exactly why that is, but we were obviously very disappointed to see that these models that we have used in the lab actually don't express GD2. And then you further out to the right you go, you see increasing levels of GD2, and you can see isotretinoin alone, or cisRA alone, didn't change the amount of GD2 on the cell surface, and neither did the KAT6 inhibitor alone, but really the combination significantly increased the density of GD2, which was not what I had ever dreamed of finding or what I had planned for, but it was really like an incidental finding. We confirmed that also in our mouse model. So we went back into the mouse, injected cells again, and treated them with the combination or with either agent alone. And here you can see the GD2 as a green fluorescent marker. And we were again confirming what we found in the lab, that we can increase significant amounts of GD2 on the cell surface with this combination of cisRA and the KAT6 inhibitor. We then were wondering, is that actually functional active GD2? Can we actually induce cell death if we combine our cells that were treated with those drugs with human NK cells and dinutuximab, or with human GD2 CAR T cells? So we put this all into one petri dish. We treated the cells with the compounds and then added on the human NK cells or dinutuximab, or in a second plate we added the GD2 CAR T cells, and here we measure cell death. So the more cell death, the higher the bar here, and we were really surprised by how much we can induce cell death. And then I want to do the same in the mouse, and I wish I were a little bit farther advanced in those experiments. So I will show you today a pilot study that I have done. I don't have the very big experiments yet, but some preliminary data. So again, we used an immunocompromised mouse so they would tolerate the injection of a human cell line, injected it into the flank, and then treated the mice with this combination treatment for 2 weeks. And here you can again see a tumor volume curve. So we've measured the tumor volume between the different treatment regimens. And in dark, black, and in brown, you can see cells that weren't treated, only received a vehicle, but then received dinutuximab and NK cell infusions three times a week. And you can see there was no difference if the mice received the dinutuximab or not. We know why, because those tumors don't express GD2. And then in pink and in red, you can see mice that received the double treatment. And then in red, the mice that also received human NK cell transfusion plus dinutuximab three times a week. And it's not a huge effect, but when we watch the mice for their survival, we see that there was a little bit of prolonged survival. Again, this is a very poor model because those mice don't have an immune system themselves, so I had to give them a human NK cell infusion to actually trigger any cell deaths, and those cells don't live forever. So you can see that, yes, there was a significant prolonged survival in those mice, but it was a very small effect, to be honest. Then I went back and did the same experiment with GD2 CAR T cells because they can survive much longer than the NK cells that I gave. Same principle, just here you see two different cell types, B2C and NGP, those are just the names. I treated those cells here all with the combination, there's no there's no control in here. And then I gave them a CD19 CAR, which we used for leukemia patients, and you can see there was no effect. Those mice immediately died and had very highly proliferative tumors. But here on the bottom, you can see in orange and brown, those are the mice that received the double treatment with the cis-RA and the KAT6 inhibitor and a single infusion of GD2 CAR T cells. And you can see really a very nice response of these animals. These animals did not have any tumor proliferation in those 2 months that we observed them. Oops, sorry. And those are the survival curves that they look much more promising. There's certainly due to the model that we used here. So to summarize those findings, I showed you that we think we found a compound, an epigenetic inhibitor that inhibits those two enzymes, KAT6A and KAT6B, that make retinoic acid, cis-RA, work better and prolong its effect, both in vitro and in our mouse model system. And we think that we also found a way to upregulate GD2 on the cell surface to hopefully make GD2 targeting immunotherapies, including dinutuximab or GD2 CAR T cells, work better. I want to give a quick outline. This is a busy slide, and I don't expect anybody to read, actually. That is more to illustrate that there's now many more companies making KAT6 inhibitors. So Pfizer started all of this a couple of years ago, and as I alluded to earlier, they are in phase 3 now with their molecule for patients with breast cancer, but there are many more companies coming and making similar compounds, and they're between phase 1 and phase 2. I quickly spoke about side effects earlier. What Pfizer has reported so far is mainly neutropenia and thrombocytopenia. We were obviously thinking, how could we ever translate this into a patient? And I'm not a translational investigator, so I rely on the help of other people. And luckily at Dana-Farber, we have Steve Du Bois, who runs our early clinical trials. And he and I sat down and thought about, okay, how could we even design a clinical trial if ever any of these companies would be open to talking to us? And, with Pfizer being now in their phase 3, they have a lot of pressure from the FDA to develop a pediatric plan. And we have, I can say so much. I think they're open to conversations, but as we all know, we don't know yet where these conversations will go. For the future, I think for myself, I will think more about the mechanisms of GD2 expression and how we can make more GD2 on the cell surface. That GD2 synthesis pathway is pretty complex. I think I'm going to spend hopefully more time in the future thinking about epigenetic ways to increase GD2 on the cell surface. I'm not the only person who thinks about that. There other groups have had similar approaches, but we haven't had a very comprehensive analysis yet how we can improve GD2 expression. And then, as always, the translational aspect of this work, trying to like translate our findings from the lab potentially into the clinic is really what drives the work in the lab. And with compounds being now in phase 3, I hope that we will have an open door eventually for a translation into the clinic. Yeah, and with that, I come to the end of my presentation. I want to thank all of you and your children for participating in clinical trials. There's so much that we as physicians learn from, but also that we bring back to the lab and study more in the lab. And this is how we can make progress. There are a lot of other people involved in my research, and I really love that about this part of my work, that these things are only possible if you collaborate with your friends and colleagues all over the country and internationally. And as you can see also on my slide, there's a lot of foundations that believed in this work and that supported it, and without that, it wouldn't be possible to make that progress that we do. So with that, I thank you all for your attention. I'm happy to take any questions.
Thank you, Dr. Layton. Does anyone have any questions? No? You got them all. You got them all. Thank you very much. Oh, yeah, go ahead. Go ahead. Please, yeah, stand up and go to the mic, please. Yeah.
Hey, thanks for the nice presentation. So I just want to understand completely, the charts you showed with the KAT6 inhibitor, did you, every time you stopped giving the KAT6 inhibitor, eventually you saw a rapid upswing, or did you, could you go back to that and just comment on that?
Yeah.
That's my question.
Yeah, let me see.
And so what I'm really getting at is, would the kids have to take a KAT6 inhibitor for their entire lives?
Yeah, that's a really good question. So, really good question. I think I have to do more work to give you the definitive answer, right? As you can see here, there's a 1 month treatment cycle. I'm actually doing more follow-up studies at the moment. But here, from this 1 month treatment, I can tell you, yes, it was necessary. Yes, I do have data from in vitro, so from cell lines in plastic, that I think eventually I can stop this because those cells are so differentiated, there's no more growth. That takes about 2 or 3 months, right? But I don't have that data yet for the mouse. Obviously, that would be ideal to eventually be like, okay, we differentiated them so far. But that always gave me concern, right? Like differentiation therapy just to stop a cell, the cell is gonna find a way to like escape that, right? So that's when we found that GD2 part, we were super excited. We were like, oh, we cannot just only stop them from dividing and making new baby cells, we can actually kill a tumor cell, right? So I think that's the pretty part that I would be much more in favor than just like making a tumor cell stopping to grow.
Thanks.
Thank you.
Okay, another question? Yeah, we've got a couple of them. Yeah, you can come up to the microphones.
Thank you for your presentation. So in our case, we've been doing a lot of treatment with naxitamab, which targets GD2, and it's started to not work as well for our son. So with what you presented with the PF9363 plus isotretinoin, right? That combination, that can increase the expression of GD2. Can you just talk a little bit more about that, and would that be a potential option in our case?
Yeah. So everything that I presented, unfortunately, is still experimental, right? Yes, CSRA or isotretinoin is available, but the KAT6 inhibitor is not available to children. It's a relatively new compound that multiple pharmaceutical companies have been developing similar compounds. They're in phase 1, 2, Pfizer's at phase 3, but unfortunately not available to children. How about adults? Is it available to adults? Yeah, so it is available to adults if they have breast cancer and are enrolling into a Pfizer trial for breast cancer. Yeah. But again, they're in phase 3, so they're making pretty rapid progress. I do think that we don't know yet enough how GD2 is being downregulated, especially when patients have been receiving dinutuximab or other antibodies for several cycles. What the mechanism is. In our hands, when we looked in our cell lines of neuroblastoma that don't express GD2 on the cell surface, we can tell it's the epigenome. So it's the epigenome that closest, at least in some cells, closes the DNA up over one of the key rate-limiting enzymes that makes GD2, right? So if the epigenome is closed at that locus for one of the enzymes and not available, that gene is turned off, so no GD2 can be made. How the cell decides to turn that off, I don't know yet. And how we can open that up, that's what we are working on. We know this double treatment with CySRA and the PF opens up the chromatin at one of those enzymes, but can other drugs do that too? We don't know yet.
Another question? Did you have one? Hey, come on. We'll do more. We'll do more.
I'm not going to ask you about GD2 in the mice tumors when they relapse, but have you looked at the combination, what effect has on normal tissue, especially considering the clinical trial on neurons, for example?
Yeah, obviously super important question. We haven't done like a broad GD2 screen of all tissue in the mouse treated with the double treatment. I can tell you a couple of things. One, the mice seem to be doing okay. That means they're not lethargic, they're growing healthy, they don't have weight problems, they don't have any very overt toxicity. We are right now collecting the tissue of kidney, liver, bone marrow to really see is there any toxicity. The other thing that is important with this compound that Pfizer shared with me, it doesn't penetrate the CNS. So I think that's also something to consider, especially if this were ever to go into children. But yeah, more to come.
Anyone else? No? Okay. Thank you, Dr. Lady.
Okay. Thank you.
Okay. Our next speaker is Dr. Wolchenbaum. He's a professor of pediatrics and the associate chief research informatics. Do you want to do it?
You're doing great.
Officer for shorten it. He's the associate dean of master's program. He's doing. We can go on and on and on. But he's. We've had Dr. Wolchenbaum speak before, and he does a lot of the bioinformatics and the databases at the University of Chicago. And we thought, again, kind of another AI type of discussion. So Dr. Wolchenbaum will be talking about that.
Great, thanks, Pat.
Thank you.
All right, so glad to be here today. I've been doing this, I haven't done one of these in a couple of years, but Pat had me coming back probably 15 years ago to do some of these. So it's been a long time. It's great to be back, and I'm looking forward to talking to you today. So this talk's gonna be a little bit different. This is a little bit more about my vision about AI and medicine and where I think things are going. The title of my talk is supposed to be a little bit provocative, that AI won't cure childhood cancer, but it's going to help the people who do. So consider a 3-year-old boy in a small town goes to his pediatrician. He has irritability, unsteady gait, and his eyes are dancing around. Now, I don't have to tell this audience what that looks like and what that means, but to a primary care doctor in a small town, this may be the only time in their life they see something like this. And it can be very difficult, and you all have these stories of what it took to get diagnosed. It can be very difficult to make that diagnostic journey. And finding the right answer often depends on finding the right person. And I know in 2026 that sounds crazy, but that's still the case. Where do we get our information about how to take care of patients and how to diagnose patients? There's many places we can go. We can go to the literature, we can talk to our colleagues. Once we have a diagnosis, we can use a tumor board mechanism to find out how to treat a patient. There's databases full of clinical trials. Now, of course, we have AI you can ask questions to, and I can tell you right now that AI would probably get that question correct with even that limited bit of information there. But the fact remains that there's an experience that physicians have over their lifetime that accumulates. And sharing that experience is what I hope I'm going to convince you is one of the most important things that we still can do that's still going to power so many of the advancements that we make. Think about how when a child moves from hospital to hospital, the data stay locked down in that hospital ecosystem. As a child crosses institution, their data usually stay in the same place. And the hospital remains the center of the record even after the patient's moved on. And I know that we have things like Care Everywhere and different ways to share data, but people are still carrying CDs around with PDFs on them and images and trying to find a computer. I don't know about you, I don't have a place to put a CD in anymore. So in the hospital, there's a special computer in the corner that nobody's allowed to touch because it's like the CD computer where CDs from other hospitals have to go in to read off the radiology. This is still a big problem. The data are locked down. But what if the patient became the center of the record? What if the patient owned and controlled their own data? What if the patient was able to pull their data from the different electronic health records and then use those data for all different kinds of things, like a research data commons, or to power a clinical platform where doctors could look for other patients that have the same presentation? Or what about just having the data themselves for their own personal health app to power their survivorship journey? There's so many different things that can happen once the patient becomes the center. So I think the next major breakthrough may not be the next best AI model. It might just be giving patients total control over their own health record that allows them to have access to it across their lifetime. So to see why this matters, I think we have to first understand what AI needs and why childhood cancer makes that so difficult. Again, this is provocative, but I think childhood cancer is one of AI's hardest tests. Because what does AI really want? AI wants large, massive data sets with common diseases, colon cancer, breast cancer, prostate cancer. It wants things where there's frequent events where it can train over lots of different things that happen to the patient. And it wants dense expertise. It wants 3 or 4 clinicians at each hospital that study that very specific event. But pediatric oncology has the opposite of that, right? We have, thankfully, very few diagnoses, less than 15,000 cases a year in the US. So it's about 1% of all cancer diagnoses if you bring the adults in. It's very rare diseases, so pediatric cancer is starting off as a rare disease, but we're talking about rare subtypes of rare diseases. It's the rarest of the rare. And within those, there's rare events that we try to track, and expertise is scattered. Now, certainly, pediatric oncologists like us, we have to know and take care of many different kinds of cancer, but when it comes down to really rare types of subtypes, you may only have 1 or 2 or 3 people in the country that are really experts in that one particular area. So before AI can learn, I argue that medicine has to be able to remember this experience. And it used to be that in the 70s, that the experience was with the physician. They saw the patients, they learned about lots of things, and then they died, and that experience was with that physician, and that it doesn't move on. Over the last 40 years, that experience has now become evidence-based medicine, and we have lots of experience in the literature. But now we have to figure out how to harness that experience for AI to be most effective. I have a couple examples here of where we've been able to share experience and really change practice. So these are all based on cases that we can pull out of using the data that are in the INRG, the Neuroblastoma Data Commons. So as you know, neuroblastoma stage 4 is a unique form of neuroblastoma where the metastases are confined to the distant lymph nodes. There are small cases, and a small number of cases, and small case series hinted that these children actually did unusually well. So while they had stage 4 disease, this distant lymph node presentation, for whatever reason, these kids did much better. But there wasn't enough data at any single site to actually prove this. So what the INRG group did is they took the data and the data commons, they pulled together over 2,000 patients, and they actually did the study. And they found in this group that 6% of the patients had 4N disease. So they compared the outcomes of the 4N patients to the stage 4 patients. And what did they find? They found that there was an 85% survival in the stage 4N kids. And the other kids, of course, did much more poorly. So what does this tell us? This tells us that we could probably spare chemotherapy for these kids. We can avoid high-risk therapy and stem cell transplant for these kids, radiation to the primary site, the hearing loss and organ toxicity associated with treating them, and any of the long-term secondary cancer risks. So understanding this 4N subtype and how it did was something that no single hospital could do by itself, but it was only possible because we shared data between lots of different institutions. We shared our experience together, and that's what our data commons do. They allow groups to share their experience. Let's look at risk classification. So neuroblastoma histology already folds age into its scoring, but when we looked at how we were classifying and stratifying kids, age was actually getting counted twice. So no single cohort was able to untangle all these factors. So again, the INRG came together. They pulled together lots of patients into a single harmonized group to study. They broke histology into its parts of diagnostic category, grade, MKI, and so forth, and they tested each of these. And what they found is that category and grade and MKI are each independently prognostic. So this was adopted into the 2021 risk classifier. It now clearly defines eligibility for clinical trials and treatment. And importantly, look at this last bit. 1 in 30 non-high-risk children are now reclassified as high risk. So these are kids that before would not have gotten enough therapy that are now being reclassified as having high-risk disease. And the only way that we were able to do this was by putting together data from lots of different places. We now have over 20,000 kids in the Neuroblastoma Data Commons, and that's because we've been able to work with people all over the world to pull the data together to do these studies. One more example. This is a more recent paper about a pipeline that tries to promote new targets for neuroblastoma. Mark Applebaum, who spoke earlier, is one of the senior authors on this paper, along with Steve Skapek. And what they did is they developed a pipeline called IEXN, which would actually look at the data in the data commons and multiple data sources. It used deep learning, AI deep learning, to read tons of papers on neuroblastoma targets, and then they used a Bayesian classifier to try to promote which targets might be druggable, in addition to the normal targets we think of. So they identified 47 candidate driver genes, including some new ones. And it was validating that they found NMYC and ALK, which of course they expected to find, but they also surfaced some new targets that were new and potentially druggable targets for neuroblastoma. Both of these some of these have inhibitors already tested in children, and they're confirming these in the lab. So this, I think, was a great example of how being able to look at massive amounts of data at the same time allowed you to explore and to identify new targets for neuroblastoma. So AI can now read all the collective literature and recommend new targets, but a target is not really helpful unless you can get it into a child in a trial. And I think this is where the system also falls apart. Some of you may have seen this picture that I show. This is an actual picture of tables from a clinical trial. Clinical trials are still written in Microsoft Word. They're still sent around as PDFs. They still involve tables like this, full of acronyms and subsets or superscripts and subscripts and notes at the end. I would even say the most modern technology would have a hard time reading this and turning it into something computable. But this is still the state of the art for running clinical trials. So when we look at ways to match kids to clinical trials, believe me, us clinicians are just as vexed and confused as parents and families are trying to read through these trials, understand trial eligibility, and understand how to figure out which trial matches which kid. So we worked hard to develop a tool, and it's in the development phase still, where we want to be able to match kids to trials very quickly. This Gearbox platform was a pilot that was set up by the Leukemia and Lymphoma Society, at first for AML patients, and now we're trying to expand it to other disease areas. And we can take, let's take an example patient. So here's a 10-year-old boy with refractory neuroblastoma who's had, of course, surgery and chemo and radiation, MIBG, and maybe has NMYC amplification. But this is now a child that is having refractory disease that you want to find a trial for. So you go into the tool. The tool will show you that there's many trials available, and we've gone to the trouble of extracting all the criteria from these trials using large language models and AI to pull out the criteria. And right now it shows that all these trials are undetermined. There's 18 of them in there. And as soon as you start to enter information, just little bits, neuroblastoma, here's the age, here's the sex, you start to see now that some of the trials move into this undetermined category. There's 5 neuroblastoma trials in there, so they all get elevated to undetermined. And as you enter more and more information, the trials will then sort. And as you enter more what you know about the patient, you here get a potential match of a trial. This takes a couple of minutes to do. It's all manual input right now, so we haven't tied it to electronic health records, but we will. But this is a very powerful way to find very quick potential matches. This doesn't say for sure the patient is a match, but this says at least that your child is a potential match. And this is a tool that is meant for patients and parents to use to try to find matches on clinical trials. Our goal is to get extra funding to try to expand this, to get in lots more neuroblastoma trials, and to start to do testing in the parent and advisory community so that we can see how this could be a useful tool. But again, we couldn't have done this 10 years ago because we didn't have the tools to pull out all these criteria from those complicated trials. And now, using modern AI, LLM techniques, we can actually pull the criteria out this way. But this platform gearbox only works because the data are already there and structured. None of this exists without the one thing that we actually can't engineer, which is the trust for sharing the data. As I mentioned, AI really requires and loves to have very large data sets with a diverse patient population and longitudinal records where we can see the record over many, many years for the patient. To do really good collaborative science where we share data requires institutions from around the world, where you get a diverse set of patients and you have a sustained collaboration. And the one thing that this requires is trust. I've been at this a long time, and we've got data now from all over the world, from 6 continents, from 40 different countries in the data commons. And while some of that is technical, like getting the data harmonized to a single standard, I've come to believe that most of the success that we've had is because of trust. It's because you put people in a room together, whether it's a virtual or a real room, and you get them to believe in a common cause for sharing data, and you get them to understand that you're here to protect their data to make sure it's used in the right way. So one of the reasons, and I think the main reason that our data commons efforts have been successful are not because we have the best platform. I think the reason is because we have gotten people to trust us to do good things with their data and to take care of it. So I think the biggest bottleneck for using AI for things like pediatric cancer is not the computational aspects. I think the biggest bottleneck is still going to be the trust and willingness to share data. And we're still driving forward. We're trying so hard to get data from other parts of the world. We're going to India this year. We're going to Hong Kong. We're going to South America. All of this is in the name of trying to get more data for sharing. So I want to walk you through what I think trust really looks like. And so this is all going to culminate in my argument that the patient needs to be the center of the data sharing journey. And this is going to seem familiar to many of you. And when I present this to non-parent audiences, they're actually very surprised to see how what this diagnostic journey can actually look like. So let's take a 3-year-old patient in rural North Dakota. And the patient, you can see in the bottom there, those purple, those are visits that this patient has had to their primary care doctor. And the patient is just getting their regular child checkups, and they're just going to the pediatrician to get their vaccines. And then all of a sudden they end up in the emergency room. Let's say they end up in the emergency room with irritability, unwillingness to walk, and eventually they are found out to have a tumor. Well, this tiny little emergency department in this tiny town is not going to be equipped to go through the whole diagnostic journey with this patient. So then they go to Fargo, where one of my colleagues, Dr. Wyatt, works, and they actually have a really great pediatric cancer program in Fargo, North Dakota, and they go through the whole diagnosis, and they find out that this child has neuroblastoma. Now, the child may get diagnosed, and then they need to start their care. They may end up having to go to Minneapolis for MIBG therapy. And then they may have to come back to Fargo to get their chemotherapy. They may have to go to Rochester to Mayo to get proton therapy. And then eventually they'll come back to Fargo, well, they'll get their chemotherapy, and they'll go back home to get their other therapy. So already you can see that this patient has been to 5 different sites. They've gotten multiple kinds of therapy. And you can imagine how challenging it is for the family to put all this information together in one place, let alone us as researchers to try to put all this data together. Now, the family may then find that this child has a major depressive episode in the middle of this, and they get hospitalized for it. So here's another example where the medical records are going to be difficult to share. The father may get stationed in Tampa, so they have to move. And then the child may end up moving to Boston to go to college, or then moving to New York to go to get a job. So now we have 8 different medical records, and now the child, now adult, information is scattered across the country. And I don't know about you, when I was 25, the last thing I was thinking about is where are my medical records? I had a little tattered vaccine thing that my mom kept for me, but that was the only information I had about my medical. And we're actually still using those tattered vaccine cards. So this is a really good example that I think of how fractured our information system is, even in this modern age. So this person may have had problems with infertility, and when they go in to have, when she goes in to have infertility checkup, they may ask her, "What did you have for chemo? What was your therapy?" Do you think she's keeping tabs on her pediatrician in this small town of North Dakota now 20 years later? Probably not. And then she might show up years later with a secondary skin cancer from her treatment. And it's going to be very hard to counsel and take care of these patients if they don't have access to the most basic information about their care and their treatment. Now, if we look at clinical trials data, this is what a clinical trial captures, that little tiny blue box there. The diagnosis, the treatment, and maybe a couple years of follow-up. We're running a study now called the Resilience Study, where we're going to patients themselves to get their medical records, and that allows us to capture the entire journey of the patient. That patient can give us access to every single hospital that she's been at, and we can look at her entire record and produce a longitudinal, harmonized record of all of her information into one single place that can be used for all sorts of important downstream uses. This continuous record is not something that we're making up. This is real. And I guarantee that some of you in this room have already used the technology that is needed to make this happen. This is actually in the US based on a legal foundation called the 21st Century Cures Act. And the 21st Century Cures Act mandates that hospitals share their data with patients, not on CD, but in a way that is computable, that is in a way that can be shared and that can be used and put into a platform that can be computed on. Every major electronic health record supports this access, and the patient is the one who controls the connection. And if any of you have taken your iPhone and opened up your mHealth app and connected it to your hospital to pull data out, you've already used this technology. It's baked in. It is there for thousands and thousands of hospitals across the country. You as the patient have the right to give access to somebody to access your data. And this is really important for the kind of research we want to do. Because right now, if we want to get data from patients around the country, we have to go to every single hospital, open a protocol, put an IRB in place, and request the data from each and every hospital on behalf of that patient. In this new model, the patient gives you access. The hospitals have nothing to say about it. It completely de-risks this. We don't have to go site by site. The patient authorization is across multiple institutions, and it can last for a year. The data flow can go directly from the hospital into a research environment, and then it creates a reusable resource for future modeling, whether it's AI or other types of downstream analytics. And so this has really been a huge breakthrough for us in the last 2 years. We're going all in on this technology because we think it's the future of data sharing and what we call real-world data, which is the full complement of the electronic health record. So looking at this diagram again with a little more detail, now the patient's the center, and they can give you access to all the hospitals they've been at through this API, this connector, and now the data can flow seamlessly from the hospitals into a research data commons or other downstream uses. So we're doing this now. We've enrolled patients who are survivors of cancer. They're giving us access to their data. We're collecting it all. It's going into a single longitudinal record, and we're going to give those data back to the patients to use, and we're also going to use it for downstream study about survivorship, and we're going to show how we can use AI tooling to do analytics over those data. So the old way, it's not that simple. Every hospital has to put governance in place. The data are frozen at the end of that protocol, so if we want to get more than clinical trials data, we have to work a lot harder, but if you're getting the clinical trials data, you're just going to get that few years like I showed you. Survivorship research is often very difficult to do because of the way that we cut off following patients after a couple of years. And just putting in the data use agreements takes 6 months to a year and a half. Not to mention that we have to pay compliance experts to work on these agreements. It's really, really difficult to share data this way. So the voluntary patient API is just one consent. The patient controls everything. And like I said, the record follows the person. And now we can actually see these late effects. We can try to understand, why does somebody get secondary cancers? Why does somebody have a cardiomyopathy? Why do certain people develop breast cancer in a radiation field, whereas other people do not? These are the kinds of things that we can finally study now that we have this deep real-world data from the electronic health record. So getting to the end here, I think for me, it's been a journey over the past 50 years to how experience becomes computable. For the last 40 years, it's been clinical trials where evidence becomes shareable. There's a publication record. We have trials that have been put out there. We can read the results. We can use that to inform future studies. And that's been the way we've done medicine now since the 70s. The data commons work we've done over the last 10 years is how we make this experience shareable. We have data on over 46,000 kids in the data commons. Over 20,000 of those are neuroblastoma patients, thanks to the work of the INRG and its long history of sharing data. And that has allowed us to do, now I think approaching 90 different papers that have come out of data in the Commons that are all based on this large harmonized data set that we've put together. But I think the next frontier is how this experience becomes computable. How do you take the data we have in the Commons and make it available to AI systems so that we can actually do studies that would normally take a long time but do them very quickly? How can we do work like the IEXCN paper where you have a deep learning model read thousands of papers and then you take all the data we have and try to understand how to better analyze those data? So I think AI is going to be the newest innovation, the new kid on the block, but it's not going to work unless we have good collaboration and good data sharing. The questions I care about the most are not the ones getting asked. The ones you hear about all the time are, what model is best? Is it Claude? Is it ChatGPT? Is it Gemini? How many billions and trillions of parameters are there? And will AI replace doctors? And is it safe to use? Those are all the common questions we hear, and I have lots of thoughts about all those things. But what matters to me is which experience is available. Do we have experience in our data commons from India yet? No, we have no data in the data commons from India. We're going back to India to try to get data, because if we can get 10,000 patients from India into the data commons, all of a sudden those data become that much more valuable. We have that much more experience. How many patients do we have for any one disease, but any rare subtype? Do you have dozens or hundreds of patients for a subtype that you can now study? Can expertise reach every patient? So are there patients being diagnosed all over the world where they don't have access to the information? Of course. One stat that I think is phenomenally depressing, and I'll say it right now, is that most of the kids in the world who die of cancer were never diagnosed with cancer. Now that to me is really startling, right? There's kids all over the world who show up with fevers or bleeding and they just die and they're never diagnosed with cancer because their countries don't have the systems in place to help figure out what's going on. We need to understand how to get this experience out there into the hands of the community so they can understand what's presenting. And of course, is AI safe? To me, it's who's left out. Who's not in the models? Who doesn't have access to the models? These equity issues are extremely important. So my prediction is that the most important breakthrough in pediatric cancer going forward is not always going to be the model. It's going to be giving patients or their parents control of the experience. And the question is not whether AI is going to replace physicians. It's whether every child's experience can help the next child wherever they're treated. And every child in this story is part of that experience, including the ones who aren't here anymore. And when that experience is shared, it doesn't disappear. It becomes what helps the next child. This is my group, Data for the Common Good at UChicago. We have lots of course, as you'd imagine, programmers and data scientists. But we also have a lot of people that work on program and project management, on compliance and data sharing and legal agreements. This is an incredibly important matrix group that helps to bring all these skills together. And of course, we are very grateful for our funders, and I want to make the point that the kind of infrastructure I'm talking about here is very difficult to get funded. The government has traditionally not wanted to fund infrastructure projects. So we have been very, very reliant on groups like yours and like other philanthropic groups around the country that have provided really important funding to keep these projects going. I don't see this changing. I don't see the government stepping up to do this kind of work. So of course, very grateful for the ongoing support that we've had. And I will stop there, and we have plenty of time, I think, for questions if people want to talk about anything I presented today or anything else. Thank you.
You're good. Thank you for the presentation. You mentioned trust a good bit of this, and I think that is a very valid piece. I guess, just from our experience, my daughter, I've gotten several letters like her data has been breached over the years about all the different, medical institutions she's been to. She's gotten more data breaches than I have, and I'm, been on the earth a lot longer she has. How can we feel confident that data is protected and safe and things like that in this type of environment? Which I think you're right. I think getting more data gets you more answers. How do you do it in a safe way, I guess?
Yeah, so there's a couple, that's a great question, and it's a couple things. A lot of the times we work with de-identified data, which of course makes it a lot easier to share, and then you have to worry less about patient's identity becoming exposed. But even if you're sharing de-identified data, there are risks, because if you take a very rare disease in a child and you have even a little bit of geographic information, whether or not the name is there, it's often fairly easy to figure out who that patient is, because they're in the newspaper, they have bake sales, they come to their school. So I would argue that just because the data are de-identified does not mean that it's impossible that somebody's going to get re-identified. What I've showed you today is actually identified data. We're actually getting fully identified data from patients. And so we take incredible care to make sure that the systems we use are fully compliant for security and HIPAA. But your security is only as strong as your weakest link, right? And so if you have a study and you share your data with somebody, you put a data use agreement in place and that person, signs and says they're not going to share the data for anything else. But if we share the data with somebody and their system gets breached, then we've lost control of that data. So it's up to us to make sure that we put every single system in place that's possible to make sure the data are secure. And you as a parent have every right to demand to know what those systems are, to know how the data are being accessed, to know what it's being used for. This is not what you asked, but one of the things we're trying now to do is we're interviewing parents and patients to understand, what do you want back? If you share the data, what do you want to get back for that? Do you want to know what papers the data were used in? Do you want to know what studies they were used for? And we're finding that a lot of people really want to know how the data are being used, and they want that return of information to parents and patients. So we're working on that. I think the security issue is not going to go away. Two last things I'll say about that. One is, it's a little bit provocative, but I would challenge to say is think about what the actual risk is. So you said your daughter's data has been breached a few times. I would hope that even with those breaches that there hasn't been any lapse of security or that there hasn't been any problems as a result of that. But if there are problems, I think we must have a legal system in place that makes sure that we protect people. So as you know, there's lots of legal protections that if you are found out to have, say, a chronic condition that can't be used against you for insurance, that's a legal protection in place that helps protect people if their data are breached. And then I'll finish by saying that there's no guarantee ever that your data are going to be secure. If anybody ever says to you, it's impossible for your data to get out, I would turn the other way, because there's no such thing as completely secure data. We can put in as many security things as possible, but a bad actor who really wants to get in and figure something out is almost always going to be able to do that. So I think it's a combination of trust, security, privacy, and legal responsibility that all have to be in place. But you as a parent have a right to know all of that. And if somebody just says, give us your data, we'll take care of it, I would ask a lot more questions. So thank you for asking that.
Okay, another question?
What format are you going to be giving this information to parents? Is it going to be like a thumb drive and something? What's the format that?
Yeah, we'd love to. We're interviewing parents and families right now about this, and we'd love to talk to anybody who wants to give information. My vision is that the data would be available in some cloud-based format, and you'd have a QR code so that you could scan it, and you could say, give it to your doctor and say, here's my record, and you would scan it, and it would come up. I think having something that is highly secure and cloud-based will ultimately be the best thing for patients and survivors to have. I always get a little bit nervous when I start sending things around on removable media that gets lost easily. But we're trying to figure out the best ways to do that right now, because anything that we put forward is going to have its pluses and minuses from a security and from a convenience standpoint. So we'd love to talk about different ways. And maybe there's multiple answers to the question. But it's a great question. And like I said, if anybody wants to be involved in these discussions with us, we'd be happy to have you part of our user groups.
Okay, go ahead. Yeah.
If a child has already passed away, is it still beneficial to collect all their data?
This is something we've been wrestling with, because the technique that I just showed you of getting access to the EHR stops when the child dies. In fact, access to MyChart is turned off 90 days afterwards, and the MyChart access in Epic is actually the way that we get the data. I would say the answer is it's more important than ever to make sure that we have access to that data. And especially when we're studying, it's like we're trying to do a glioblastoma study now, so obviously a highly fatal disease. And most of the data that we want to get are from children who've already passed away. And so having access to those data through the parents or other means is incredibly meaningful and important. And if it's an area you're interested in, we'd love to try to work together to understand how we can make that as part of our data pipeline. It's incredibly important.
Yes,
Yeah.
I would definitely
Okay, I'll
submit.
talk to you right after. Thank you.
Okay.
That's great.
Okay. Yeah, go ahead.
So you talked about collecting all the medical records. Is there possibly a way, like in the future, like your Google Health app, so say our kids are going through treatment and we want to record like what they're actually doing, like maybe they're taking a supplement or maybe they're eating, that all that stuff can be logged in there to be kind of used as a data set to maybe you can track like, hey, he ate something and he's not having C. diff as much or something.
So one of the beautiful things about going directly to the patient is that once you establish that relationship, you can do almost anything you want with the family that's willing to share. So we're already looking at patient-reported outcomes, surveys, using an app to log diet and sleep, collecting data from wearables that we'll be able to pull in. So once we've established that connection and the patient has signed up for our study, it doesn't just end with collecting the electronic health record. We can do all these things you're talking about. Because as you know, the complete picture of the patient is not just what's in the hospital record. It's your Walgreens and CVS information from pharmacy. It's where you go to get your infusions. It's days of school that they've missed. It's how they've slept. It's what they've eaten. And once we can start to pull that data in, we're going to get a much more rich picture to do exactly the kind of things that you're talking about. Yeah.
Anyone else? No? Okay. Thank you, Dr. Boltermup.
Okay. Thanks, Pat.
Okay. We're going to take probably about a 15, 20-minute break. I don't know if the food is out there or little snacks. Like I said, we keep eating, so hopefully there'll be some snacks out there, and we'll take about 15, 20-minute break.
Smart shit is pretty slick. What's next?
Just manifesting my future.
You and that laptop are going places.
Start strong with a Lenovo Yoga Aura. is your summer in a can. Limoncello, crafted the Italian way. Real fruit juice, a pinch of
for the acute treatment of migraine with or without aura in adults.
Can I have everyone's attention? We'll go ahead and start. We've got a couple more speakers. Let's see, I'm looking for somebody. Our next speaker, again, me and my absent-mindedness and my internet connection. I don't have my intro for Dr. Modak, so he's going to self-introduce himself. That he's going to be talking today on the MSK update on their trials and their vaccine studies. Dr. Shaquille Modak.
Thank you so much. I confess I do work at Memorial, so readily confess to that crime. But I want to thank Pat, who's done this for so many years, and really it's been a mission for her and CNCF, so I really appreciate that. So I was asked to give an update on MSK, what we are doing there, and since we are outside the COG, we do things a bit differently and for better or for worse. So I wanted to not talk so much about vaccine, but kind of give you an update on where we are currently, and these are my disclosures. So I want to touch base on these topics. A new induction treatment, which is halfway through accrual. Recently, we published a lot of information on naxitamab and how we use it, and the efforts that we are making to reduce some of the side effects of naxitamab. I'm not going to talk so much about bivalent vaccine. Perhaps things will become clearer as to where we are going next year. But we're quite excited to announce that a new trial for CNS relapse has opened, and we'll be treating the first patient next week. And I'll give you a background about that. I recently got back from a meeting on neuroblastoma early drug development, and Araz, my peer and partner in crime, was also there. So I want to share some of the ideas about where things are going with newer approaches to neuroblastoma. And then lastly, something that we are kind of excited about, looking at a new molecule called DLL3. So these are kind of disparate things, but I'm going to touch base on them really quickly. So as some of you know, or most of you know, we have not been doing bone marrow transplant for neuroblastoma for the last 25 years or so. The goal being to try to reduce treatment while maintaining a remission and good outcomes. And to the point where we are kind of crystallizing our ideas into that some patients with neuroblastoma will be very chemosensitive and others will not. And by exposing everybody to high-dose chemotherapy, we might not be doing our patients any favors. So the current protocol, N10, is based on a pilot study which Dr. Kushner ran, where we removed cisplatin altogether, which is a drug that causes hearing loss, and we gave only 4 cycles of chemotherapy as induction. So patients got 3 cycles of chemotherapy, got surgery, then had 1 more cycle of high-dose chemotherapy, and after that we decided what to do. So this is an adaptive study, which means that we don't a priori decide exactly what treatment to give, but do the 4 cycles, assess response, and then determine the next step. So we first enrolled 15 patients, and a total number of 26 patients are enrolled, has not been published yet. But in these 15 patients and then the 26 patients, we definitely did not, patients did not experience any hearing loss. The first 15 patients, because that was the first analysis, we could, all of them underwent surgery appropriately, and the response rate, that means total CRs and PRs, that is complete and partial responses at the end of chemotherapy, was seen in less than 50% of patients, or less than 60% of patients. But when we gave these patients antibody treatment, and I'm going to show you some of that later, we were able to achieve remission in almost all our patients. So the first goal was, can we achieve remission with 4 cycles of chemotherapy plus 2 cycles of antibody? And the answer to that was yes, and that was why we embarked on the N10 study. The N10 study has the same chemotherapy backbone. Cycles 1 and 4 are high-dose cyclotopo. Cycle 2 is ICE, that is no cisplatin involved. And cycle 3 is cyclophosphamide, doxorubicin, and vincristine. And this allows us to add antibody treatment early, and we are, like this, most of you know the St. Jude study, that earlier addition of antibodies seems to give you better complete and partial response rates. Whether this is going to translate or not into everybody's experience is still being tested by the COG. But we also had some inkling that early adding mouse antibody earlier on in chemotherapy seems to give us better response rates. But this is now kind of one of the reasons why we embarked upon this study was that can we add antibody early on and allow us to be more adept and agile in patients who don't respond to antibodies. So our kind of thought is that some patients with neuroblastoma will not respond to chemotherapy however many cycles we give these patients. So there's no point in belaboring more chemotherapy for these patients. Another group of patients will have a very good response and go into complete remission. And then should we give these patients even more chemotherapy? And then some patients will be in the middle, and we think those patients should get a bit more of chemotherapy. So this is kind of the philosophy. And what does that translate into reality is that after 4 cycles of chemotherapy and surgery, if patients achieve complete remission, the CR, then we give 2 cycles of naxitamab. If they show continued remission, we give 4 more cycles. Those patients who don't respond much, say the Curie score went from 20 to 15, we say chemotherapy is not working. Let's treat them with antibody alone. And those patients, when we treat them with naxitamab plus GM-CSF without any chemotherapy, almost invariably go into complete remission, suggesting that this is truly chemo-refractory disease, not responding to chemotherapy, but continues to respond quite well to antibody. And those patients who only achieve a partial response will get chemoimmunotherapy, again, naxitamab-based, and then we will assess them after 2 cycles, and our goal is to get at least 75% of patients into remission. So 19 patients have been enrolled. We are going to do our analysis after 21 patients, and then if we've reached that mark, we will accrue further patients. Now, there are some pros and cons of this approach. It does, we don't actually add antibody after 2 cycles, but after 4 cycles, but we are able to, or we should be able to avoid cisplatin altogether, thus getting away from a side effect which can be quite problematic and might affect does affect quality of life quite a lot. So this, stay tuned, and we should be able to share our data in another couple of years, I think. So that's our upfront study, what's going on currently. We've also learned a lot more about how to use naxitamab and when it's useful and when it's not. So the study which led to its approval showed that when we combine naxitamab plus GM-CSF, we get a response rate of 50%. This was a multinational, international study. And this included patients who had relapsed and were refractory. And these very robust responses, as you can see in this chart, this is the reduction in Curie scores. After giving antibody without GM-CSF, we saw very, very good responses. And in patients who had never relapsed before, this response rate was even higher. So that's one way of using naxitamab. The other way is instead of using transplant plus antibody, we can use naxitamab plus GM-CSF without any transplant in patients who achieve remission. And in this initial group of patients, our event-free survival was 73%, and then in a subsequent group of patients, that event-free survival at 2 years, at 3 years in fact, is about 80%, suggesting that just as we observed with mouse antibody earlier on, we can achieve very good remissions or maintain remissions with naxitamab. And in the interest of time, I see I'm kind of running out of time. I'm going to switch to our efforts that we've made to reduce naxitamab-related pain. We have been using low-dose ketamine in the clinic, and using this ketamine infusions, we've been able to show that we can reduce the amount of opioid we use for pain management. And so this has been a significant improvement in pain management. My colleague in Barcelona, Dr. Mora, also found a new way of giving naxitamab using a step-up method, that is running naxitamab over initially at a very low rate and increasing the rate every 5 minutes. He was able to show that the bad side effects, which are low blood pressure and fluid requirements, were significantly reduced. So that's another way we've learned to mitigate some of the side effects of naxitamab and allow us to continue using it in the clinic. And finally, for bad rash, both for naxitamab and for dinutuximab, we've been able to use an agent called omalizumab, which is an IgE antibody, to reduce the toxicity of rashes. Now, whenever a patient relapses, we try to get patients back into remission. And after patients get into remission, we treat them with naxitamab. Again, for this group of patients who we got them back into remission, their 5-year remission-free survival is about 50%. That means patients who relapse, then go back into remission, if we retreat them with naxitamab, half of them will not relapse again. And the question we are asking with the vaccine is, can we improve this number even further? And these vaccine trials, I anticipate, will finish accrual next year. And then we'll be able to figure out whether the vaccine has a further role to play in these patients to maintain remission for a longer period of time. Another problem that we face is patients who relapse in the brain without relapsing anywhere else. And many of you know that we had a very large study, a relatively large study of patients who relapsed in the brain who received an antibody called 8H9 or omburtamab, which eventually, to cut a long story short, was not approved by the FDA for various reasons which I won't go into now. But some of those reasons we have kind of fixed, and we have now started a new study, which is being run by Dr. Wei, where we, instead of using the first generation of radioimmunotherapy with omburtamab, we combine it with a different isotope called lutetium-177. And this trial, this study is open now, and we'll be treating the first patient next week. So coming back to patients who relapse in the brain, we do strongly believe that there's a relatively high salvage rate for this group of patients. As you can see, even in the old study, we had about 50% patients could be salvaged despite having very big, impressive relapses in the brain. This next kind of slides are, again, related to what I was talking about, is a push internationally to develop newer agents to fight neuroblastoma. One of them is a PLK4 inhibitor, which was open at MSK until it ran into some trouble with the pharma company that was supporting it. Now we are attempting to revive this internationally. A lot of this initial preclinical data came from CHOP. The reason why we got involved early was because when we have adult studies open of the same drug, since we are a cancer hospital which treats both adults and pediatrics, we often have the opportunities to use these drugs earlier in our patients. So this is one study where there's a lot of excitement in the neuroblastoma community, and we hope we can revive this study going forward. Another study, which again, has a uniform excitement across MSK and internationally is another unique class of drugs called degraders, in which proteins that control the growth of neuroblastoma can be degraded and thus causing anti-neuroblastoma activity. So this, again, I bring this up because whenever we have a trial open in adults for similar mechanisms, we push the FDA to allow initially patients between 12 and 18 to come onto trial, and that has been increasingly been granted, that permission. So as we spread our net to find newer approaches to neuroblastoma, we have been able to access some of these drugs because of the interaction with the adult community. Many of you know that lorlatinib is used for patients with ALK mutated neuroblastoma. There are further ALK inhibitors being developed for lung cancer, and we take the advantage of that to try to put our patients onto with ALK mutations who have failed lorlatinib onto newer agents, newer ALK inhibitors. Finally, there's a lot of excitement using antibody drug conjugates. In this case, the initial idea was to use an antibody that Merck is developing, which combines chemotherapy with an antibody, and antibody then takes the very toxic chemotherapy only to the neuroblastoma. These are called antibody drug conjugates, and they have, not only for neuroblastoma, but for various other indications, have been quite successful. And we are hoping we can bring these to the neuroblastoma community. And another one such ADC, again, is a B7H3 ADC. A lot of excitement about this because there were some responses seen in patients with rhabdomyosarcoma, which shares the same antigen as neuroblastoma. So again, they're open because of international collaborations as well as access to the adult oncology world. And finally, we've been trying to find a new agent, a new target on neuroblastoma. One of these targets that we're interested in is called DLL3. DLL3 is a controversial target because when we look at DLL3 using various assays on in a test tube or on in vitro, we often are confused whether DLL3 is present or not. But what we did was that we took an antibody against DLL3, we connected it to a PET emitter, in this case zirconium, and when we injected patients with neuroblastoma, we found that, as you can see on the right side is an MIBG scan, but when we compare the DLL3 scan to the MIBG scan, we see almost 100% correlation with the MIBG scan, suggesting that we could, if we had a therapeutic molecule against DLL3, we could offer it to these patients. And indeed, we have, after we've done that sort of scan in a human, we have gone to Amgen to ask for treatment, and we have had 2 patients have been treated thus far with tarlatamab, based purely on trying to find a new way of imaging patients, confirming that DLL3 is present in the patient, and then only choosing that patient for trying to treat them with some novel agents which are approved for adult indications. And we are finally going to open a CAR T cell against DLL3 probably early next year, if not the last quarter. So these are kind of where things are, and I'm happy to take questions if any.
Thank you, Dr. Modak. Have questions? Go ahead.
Hi, thanks for the talk. I have a question about naxitamab, and in particular, the side effect profile compared to dinutuximab. And I mean, a lot of us just want to talk about our experiences, so I will do that. So my son, we tried to do naxitamab, and in the first round of the first cycle, his blood pressure just plummeted to a scary, scary level where teams were called in, and so they killed it. And my attention was caught by your slide then about changing the side effect profile. I think you said by titrating up, basically. Tell me about that. Is that, like once you see, I guess my real question is this, once you see such a big adverse reaction, is this something we should in general avoid forever, or is there a way to come back to this? That's really my question.
It's a kind of a judgment call. Also, it depends on what options you have, right? So to be very open, over the last 5 years, we use both the antibodies at MSK, naxitamab and dinutuximab. We treat about 9 patients a week with naxitamab and 3 patients a week with dinutuximab. So over the year, last 5 years, kind of learned a lot about this. And my practice has also evolved. For example, if a patient had naxitamab and then had a recurrence within, say, a couple of months, 3 to 6 months, then I'm definitely going to try the other antibody, and vice versa. So coming back to your question, one is risk versus benefit, right? If we have an option, then I would prefer the other option. If we don't have an option, then I would try the step-up method, because this is not a true allergic reaction. It is an on-target effect, because naxitamab is binding to those receptors that drop your blood pressure, which are on sympathetic nerves. So those blood pressures can be saturated with that's the theory, being saturated by this very slow infusion, then we will not see this effect. Indeed, we haven't published it, but when we used to see this sort of side effect, we would call a code or a rapid response team. Since we started the step up, we've hardly ever called a code. So I believe this does work. But again, it's something which, if there are options, I'd consider all the options. If this is felt to be by your doc to be the best thing, then we can try it.
Quick follow-up question. Would you recommend for someone that's had an adverse side effect, if they're going to try naxitamab again, to go to Sloan Kettering, like because you guys give a lot more of it than other places? I know this is an unfair question.
I don't know about that, but again, adverse reactions are there are adverse reactions and adverse reactions. The very bad adverse reactions of transverse myelitis, for example, where there's damage to the spinal cord, I would not treat with either antibody. But this sort of adverse reaction, we have learned over time how to manage it. But this is now, I've been evangelizing about this step-up method to all my peers, and I think if it's followed well, I don't see a reason for you to come here to us. Okay,
thanks.
Anyone else have any questions? Thank you, Dr. Modak.
Okay, thanks.
Our next speaker is Dr. Timothy Spear. He's an MD, PhD, and an instructor in the Division of Oncology at Children's Hospital Philadelphia. He's actually a native of Chicago. He received his MD and PhD at Loyola and subsequently moved east for clinical training, completing his residency and fellowship at CHOP. He joined the laboratory of John Maris during his fellowship and is currently building an independent research program focused on vaccination strategies for childhood cancer. Today he will discuss current and future efforts to incorporate various vaccine strategies into the care for neuroblastoma patients. Dr. Tim Spear.
Thank you, Pat, for that introduction. Thank you, everybody, for the opportunity to speak with you today. So I think what we'll walk through today is some basics and some history about cancer vaccines, what the initial thought process and utility of them were, 100 years ago or earlier, why they faded out of favor and what other immunotherapies really took off, putting them in the back seat, and then why there is progressively more excitement about them now, and what we're doing at CHOP to sort of push those boundaries. And at the end, we'll show a little bit of some preclinical data and what we're excited for in the future. So what is a cancer vaccine? And so unlike a lot of the vaccines that our children get at their pediatrician, those are mostly preventative vaccines. So trying to avoid serious illness from infectious diseases. But most cancer vaccines are designed to be, rather than preventative, therapeutic. And so they can be given either during treatment or after a maintenance therapy to either one, induce immune killing of the cancer during treatment, or two, to prevent relapse. And so the foundation of developing a vaccine is identifying a tumor-specific or tumor-associated marker, whether that be something on the surface of the cell, like a ganglioside, like GD2, GD3, or whether that be something inside the cell that through immune surveillance gets presented on the top of the cell to tell our immune cells, I'm a normal tissue, I'm a mutation, I'm a pathogen. And so the dendritic cells, or antigen-presenting cells, can present foreign peptides through MHC, which is a surface molecule that presents a short piece of a protein, and our T and B cells are able to recognize those, and specifically T cells are able to recognize those peptides that represent either tumor antigens or viral antigens. And what we hope to do is, in the creation of a vaccine, train a T cell or a B cell to seek out and make antibodies or directly attack either a tumor cell or a pathogen-infected cell. And so over the last 100 years or so, we actually haven't made all that much progress, maybe except in the last 10 years in terms of trying to really utilize cancer vaccines successfully. So back in the late 1800s, some people call the father of immunotherapy, Dr. Coley, had noticed that in some patients with cancers who had severe infections, namely bacterial infections, they actually had some evidence of spontaneous improvement of their tumor burden. And so he played around with that idea, eventually injecting killed bacteria or remnants of bacteria into patients with cancer, and happened to see that the immune response that was elicited by the bacteria actually had a beneficial side effect of getting rid or attacking the tumor cells. And the mechanism at that time was not very well known. He continued a lot of his research until the FDA basically stepped in and said, you know, this is too dangerous and we need to be more cognizant about the science. And that really stemmed the community to really try to understand the mechanisms of how we could elicit an immune response against cancer using vaccines. So in the late 90s, a tuberculosis vaccine was repurposed to treat non-invasive bladder cancer. And then it was another 20 years before the first FDA-approved therapy for prostate cancer was designed. And that was really a more personalized vaccine where they would take the patient's tumor cells and lyse them up and then deliver them or educate the patient's T cells outside of the body and then redeliver them. And those are two different approaches to vaccine design. And then in the 2010s, we had checkpoint inhibitors and CAR T cells arrive on the scene, and they had a lot more immediate success, especially in adults, in creating significant change and benefit in these patients. And so everybody rode the wave of checkpoint inhibition, like pembrolizumab, CAR T cells for leukemias, and cancer vaccines sort of took a back seat. And then when we had the COVID-19 pandemic, mRNA technology was credentialed, and the rapid formulation of the COVID-19 vaccine, its safety and efficacy, put mRNA and vaccine technology back in the forefront. And people, including myself, are trying to rediscover, repurpose that technology towards creating cancer vaccines. And the adult world has had a substantial success with this in two histologies in particular, melanoma and pancreatic cancer. A lot of this has been pioneered at Sloan Kettering in parallel to the GD2, GD3 vaccine for neuroblastoma. And there is a lot of excitement in the field by the scientists and now by the NIH, and there is a lot more momentum behind this technology. So different types of vaccine approaches that have been tested are up here on the screen. It started from whole cell vaccines, basically the idea of taking tumor cells and killing them and then reinfusing them into a patient or a mouse to see if the remnants of that cancer could be used to educate the T cells and try to simulate an immune response against the mouse or the human if cancer was already there or if you re-challenged with cancer. And then later, individuals recognized, which proteins or peptides from this whole category of antigens in these vaccines were the most important, and then they decided, well, let's just vaccinate with those short things that we think matter the most. And then because we knew it was immune-driven, some groups decided, well, let's take the antigen-presenting cells that are really good at educating those T cells, and let's put those pieces of proteins in them and then deliver them to the patient so they're not floating around trying to find those antigen-presenting cells, but we're delivering those instructions to engage the tumor antigens already in the body. And then groups were very good about designing instructions for the body to make those antigens and then putting them in different delivery vehicles like viral vectors or mRNA or naked nucleic acid like DNA, and giving them into the body of a mouse or a human and allowing the body to make those different antigens or those pieces of protein that we're trying to get the immune system to respond to, and have those be presented in the body in those antigen-presenting cells rather than having to take them out of the body and grow them in a laboratory and manipulate them and give them back to the patient. And we talked a little bit about why that technology fell out of favor, but now they're more promising. We have a lot of data in the adult world, both with peptide and with mRNA vaccines, and so this is being re-engaged by a lot of investigators. So it was really that mRNA technology that was refined and scaled, solving major manufacturing and delivery hurdles. That is sort of the delivery method that we are invested in at CHOP and at Penn. We have better tools now to identify those tumor-specific targets, whether they are non-mutated antigens that are expressed highly in tumor cells but not expressed or expressed very lowly in normal tissue, or true neoantigens, which we'll talk about, which are mutations that exist either through the natural history of the cancer, whether it's a driver mutation, meaning it's actually driving the formation, or if they're bystander mutations that happen to coexist but may not be necessarily responsible for the biology. And then we know that vaccines work best in combination. So in the adult world, they're giving it paired with checkpoint inhibitors, which historically have not worked or been given all that often in pediatric cancers, and they're given either during treatment or after treatment to prevent relapse. And these landmark studies, mainly in melanoma and pancreatic cancer, are renewing that investment both at the local and then at the federal levels. So early pediatric vaccine research, happened about 100 years after Coley figured out that we could inject toxins into hosts and have an immune response attack cancer. And so the earliest evidence in pediatric cancers were using those dendritic cell vaccines. So we would take those immune cells that present the antigens to the T cells, we take those cells out of the body, we load them either with the contents of the patient's own own cancer, and we give those peptides to those vaccines and then back in the patient. And it was trialed in neuroblastoma, some sarcomas, kidney tumors. It was not that effective, but it showed feasibility and safety using that technology. I think everybody here is familiar with the efforts at MSK developing the vaccine against that neuroblastoma associated antigen, the GD2 and GD3. And then we saw that maybe these studies don't cure children on their own, but they prove the approach is safe. We are getting immunogenic responses, and how do we pair that with additional therapy to improve outcomes overall? So I don't really need to talk about this. We heard a little bit about the efforts in the GD2, GD3 ganglioside vaccine. Potentially some parents here have had children treated on those trials, and I look forward to hearing what the future of that vaccine is potentially next year as they are going to using that at the end of therapy to prevent relapse. And as we saw yesterday, the traditional versus the cytokine plus vaccine arm, really capitalizing on what we know about the efficacy of vaccines and how we can improve that using combination therapy. So where we stand today, in addition to the advances of the MSK-led ganglioside vaccine, mRNA vaccines are showing preclinical early signs of efficacy and safety in animal models for pediatric cancers, and then really emphasizing vaccines to be combined with therapy and not replace anything at this time. So beyond neuroblastoma, what other evidence do we have now in the age of mRNA to suggest that maybe we could go after neuroblastoma? And I think one of the great cases of proof of concept is for some brain cancers which are driven or associated by specific mutations. And that's sort of the holy grail in a cancer vaccine is finding some mutation that's going to be presented by the cancer. It's going to be very foreign to the body, and whether or not the T cells can see it or they get assistance in seeing it with a vaccine, we can target just those tumor cells and leave the rest of the normal cells behind. And so DIPG is one of those examples where you have a mutation in a gene, it's specifically associated with that, and there are some early multi-site trials using cancer vaccines against that mutation. Similarly, there is a non-mutated protein called WT1, and more recently we've sort of revisited that dendritic cell vaccine approach. WT1 is not necessarily expressed at high levels on normal tissue, but it can be on cancer cells, and so providing those antigen-presenting cells, either engineered with mRNA to express that protein, is now shown feasibility and safety and some early immune activity in these patients. And now we're capitalizing on that experience in pancreatic cancer and designing some novel therapies for sarcomas. So the work that CHOP is trying to pioneer is focused on those mutational antigens or neoantigens. And so these are distinctly brand new foreign protein fragments that look foreign, and they're created by mutations in the cancer cells. And they're by definition not present in any healthy tissue. So that makes them ideal immune targets if the body sees them as foreign and then leaves those normal cells behind. The problem is, in pediatrics especially, those types of mutations are very rare. The ideal type of neoantigen would be public, meaning it is a disease driver. Every cancer cell is going to express that mutation because it is important for that cancer cell to turn into a cancer cell and survive. It would be found in a lot of different patients, and so if you created that vaccine, it would go and benefit many, many children or adults. And it could be sort of an off-the-shelf approach rather than a custom or personalized approach. And it would be relatively rare but high value, meaning we could develop it much faster and easier to manufacture at scale if this was going to be something we could give to a large population of patients. More often, and especially in low mutational burden cancers like pediatric cancers and especially neuroblastoma, we need to think about personalized neoantigens. So these may or may not be disease drivers, but they can be found coexisting in cancer cells despite it maybe not contributing to the major biology. It would require a custom vaccine formulation tailored to each individual's mutations. And they're more numerous in certain high mutation cancers, like some colorectal cancers and cancer predispositions. But creating those can be more slow, costlier, and logistically complex rather than making one giant formulation for a single antigen that could benefit a lot of people. When you go back to this specific comparison between adult and pediatric cancers, so melanoma can have a very high mutational rate. I think that's why they have a lot of success using those checkpoint inhibitor immune therapies and the historical success using cancer vaccines for that histology. But pediatric cancers have 14 times fewer mutations. So less than 1 million base pairs. That genetic material will have a single mutation in those 1 million events. And the core challenge is fewer mutations in pediatric cancers means fewer of those classical neoantigens, and so those kids' tumors won't give a lot of repertoire or options for the immune system to challenge and identify and eradicate. And so what we're trying to do is be a little bit more creative in the way that we're discovering these neoantigens and the way that we can create multivalent vaccines on a personal level to give the patients the instructions to be able to seek out and kill those cancer cells that are expressing those mutations. So we typically start from a tumor sample. Historically, it's been doing deep sequencing of the genome of those cancer cells, or using other chemistry means to identify proteins or peptides that are on the surface, using a lot of computational methods to screen out what's normal, trying to prioritize what neoantigens we think may be good at eliciting an immune response, and then coming up with a short list of things that we think would be best to put into a vaccine. So the standard conventional route of doing that is looking at single point mutations, looking at big regions of the genome that are flipped around and create these novel fusion proteins or insertions or big deletions. The methods that we do that is generally deep sequencing, either of the exome or the genome, so the DNA, or the RNA that comes after the DNA before it gets turned into a protein or a peptide. And what the field has really done, because we know that those peptides are presented by MHC on the surface of antigen-presenting cells or cancer cells, that allows a T cell to see that mistake in the protein, it relies on what we currently know as to the predictive models of, okay, we found this short little read that has a mutation in it. What are the chances it fits on that type of surface molecule, MHC, in a way that would stimulate a T cell? And as we're continually learning the rules of engagement, a lot of these algorithms that were created are very soon out of date and need to be updated. So the approach that we're taking is using those standard conventional routes, but sort of layering on additional methods to identify non-canonical mutations. So this can be alternative splicing, which isn't necessarily a mutation, but from DNA, the instructions to make RNA, which is how we get to our proteins, can be rearranged a little bit in that middle interim step. There are hidden areas of the genome that don't code for a protein, but that can still be expressed, and we just don't find them. Some of those are called transposon elements. And then we have a lot of endogenous retroviral elements, meaning that throughout evolutionary history, humans have been infected with retroviruses in nature. By definition, a retrovirus inserts some of its genome into the human, and those are typically not expressed, but when the regulation of expression of genes is disrupted, oftentimes in cancers, we can get these hidden regions of the genome being expressed specifically in those cancer cells, and the traditional methods of sequencing don't pick those up. Additionally, we're using proteogenomics or immunopeptidomics, where we don't look at the instructions of what proteins are made and what peptides are chopped up, but we're actually just surveying the surface of the cell and pulling off those short peptides directly from MHC to see what's there. And if we know they're there, that gives us more leverage and confidence to create a vaccine against something that we actually know is on the surface, rather than as an instruction to make something that we don't know whether it's there or not. And so the goal really is to turn these neoantigens into vaccines, get better at predicting which ones they are, and then maybe even trying to validate them before we put them into a vaccine formulation. And these can range from long peptides to mRNA, and again, using those technologies to be either dendritic cells that we manipulate outside the body, or using viral vectors or lipid nanoparticles to deliver that vaccine, the instructions to make the proteins or the peptides themselves directly into the host. And so at CHOP, the very specific things that we're contrasting to historical approaches is, as I said, instead of next generation sequencing, we're including that along with surveying the surface of the cell to see what mutations are actually presented. We are not using those MHC binding algorithms because we don't really know those rules of engagement. So if we ignore them and try to be agnostic to them, we're not going to bias ourselves against something that may or may not be worth putting into a vaccine. We're really trying to capitalize on those non-coding regions of the genome or the dark genome. And then I think what's most interesting is that while we're using prediction algorithms to figure out or predict what would be a good neoantigen to put into a vaccine, we're going to validate that on a per patient basis before we would make that formulation. And very specifically, neuroblastoma has one of the lowest rates of mutations. And so histologies like this have been largely ignored as not worth the effort, or even if you could make a vaccine, the mutations are too low to actually elicit a response. And so we're challenging that conventional thinking. And historically, vaccine valency or number of things that you could put into the vaccine would be very minimal. But now with long peptides and mRNA, we can encode many, many, many neoantigens into a single dose of vaccine. And so the schema that I'm showing is that approach that we're taking. And it really was first pioneered by the Schoenberger group at La Jolla Institute for Immunology. The NCT number up there is a clinical trial in adult refractory solid tumors where they're using this to identify neoantigens and then putting those peptide vaccines into those patients. And they are starting to see, one, feasibility and safety for sure, but they're starting to see some immune activity in those patients. So it first starts with finding a piece of tumor from a biopsy or a second look surgery where you're definitively resecting it. And we look at the DNA and the RNA sequences, so the genetic instructions to make RNA, which turns into protein, and comparing that to the normal tissue, usually a sample of blood. We get all that sequencing information, we put it into a computer that prioritizes based on historical data, so it's an ever-evolving model, and then we get the list of neoantigens. On the bottom is what we're adding at CHOP, is this immunopeptidomic pipeline where we're pulling those small peptides off the surface of the cells, we're seeing which ones are mutated, and then we're adding them into that prioritization algorithm. And that's usually where vaccine formulation stops. You fit as many of those proteins as you're confident in could be something that would elicit immune response, and you see what happens. And that is sort of the approaches that they've been taking with melanoma and pancreatic cancer. Right now, what we're trying to do is go the extra step and validate which ones actually create an immune response on a per-patient basis so we have more confidence in the ability for that vaccine to elicit an immune response in the patient before it's being made. And I'm going to try to do a little bit of math to explain why we think that matters. And so if you took the genome and you got your RNA that encodes all of your proteins, you'd have almost 500,000 different peptides that would cover all of that. You'd have no idea which ones would be neoantigens based on sequence alone. If you put through those hits through the traditional binding algorithms of, okay, which ones based on the structure do we think are going to be presented on the top of the surface? Okay, that gets us down to 1% of that 500,000. So now we're at 500,000 or 600,000 peptides. If you try to validate those, you have a lot of candidates to go after, and the hit rate of your ability to find those because you have such a big list is very low. Not really feasible to creating a personalized vaccine. But if we do the bioinformatic algorithm that we've created that is a little bit less dependent on that MHC prediction, and we use the specific confidence intervals that we've created for knowing which mutations look to be important, we get a smaller pool that's more feasible to verify, and the historical positive predictive value is around 40 or 50%, meaning if a patient comes in and we sequence everything and they have 20 very high confidence neoantigens, 10 of those will validate as being bona fide neoantigens using the patient's immune system in addition to the lab. And those 10, instead of maybe the 50 that you would have pulled out of a traditional binding algorithm, would only be made into the vaccine with what we hope is a higher likelihood of stimulating an immune response in the patients. And so that's sort of been the basis of our neoantigen discovery campaign in a retrospective manner, meaning we're going to our biobank and pulling out biopsies from neuroblastoma. We're having our pathology friends review which biopsies actually have a large enough amount of tumor for us to get genetic information. We're isolating the DNA and RNA. We're getting those sequences. We're putting it through the algorithms. We're taking samples of the tumor. We're pulling off the peptides that are on top of the surface. We're having that chemistry be analyzed. We combine those two data sets. And that extra step is then getting blood from that same patient, isolating their immune cells. When we get the short list of neoantigens that we think will make a difference, we'll challenge those immune cells with those neoantigens as peptides, and then we look to see which ones actually stimulate a response. And so this is just sort of the first cohort. We have about 50 samples that we're putting through this pipeline, and it just takes time to collate them, to get the sequencing. It's very expensive to try to get those peptides off the surface of the cell. But this is some of the sequencing prediction modeling of the first set of 15 patients. And I think the most important thing is that these level 4 neoantigens are our top candidates that are high confidence in this data set. And despite the field saying, no, there's not enough mutations to be able to find something worth going after, we are actually finding neoantigens that fulfill these criteria that potentially we could make a vaccine off of. Trying to stratify those based on patient demographics, really the only things that we noticed are that older patients have more neoantigens than younger patients, and those with MICN non-amplified disease have more neoantigens than MICN amplified. And based on the biology of those tumors, that is what we expect, so it's a good gut check for this data. And then this is sort of the readout or the fingerprint of neoantigen reactivity that we would go through and try to evaluate what would be a candidate neoantigen to put in a vaccine for a particular patient. So I'll just walk you through this case study. So this is a 5-year-old male. This is a diagnostic biopsy. This patient was MICN non-amplified and had a normal ALK mutation. We found 29 different neoantigens that were on that high short list of being very confident based on the learning model that we've made. All of them were single point mutations, and one was a deletion. We created twice as many peptides where we put that mutation at different positions, and then we challenged those immune cells from that patient in plastic dish in the lab for 14 days, and then we re-challenged them one more time. So we're exposing them. We're going to let the antigen-presenting cells take up these peptides. They're going to mingle with the T cells. We'll keep them in culture for a couple of weeks. That's sort of the priming aspect. If there are any T cells there, they're going to get excited if they see those peptides, and then we challenge them one last time. And so the T cells that have seen that peptide before, they see it the second time, and they're really going to be active. And so we look for cytokine production in these tiny little wells, and the way the assay is set up is if a T cell spits out, say, interferon gamma or a cytokine, it gets captured on the bottom of the plate, and we put a bunch of different solutions on it, and that will eventually stain with a color. And so it's called an Ellie spot. And so if you get wells with a lot of dots on it, we know that there were T cells there that saw what we put in the well and that created cytokine, and that would be a good target to go after. And so there's 55 peptides that represent 29 mutations. There were 12 that elicited an immune response. So these are pre-existing tumor-specific T cells in these patients that people are largely ignoring, that if we curated a list of mutational peptides, challenged those T cells in a dish, we're pulling out about 40% of what we predicted to actually elicit a T cell response. So there are T cells in these patients, and if we can get the right combination of neoantigens, the right delivery method, and the right adjuvancy or immune stimulation when we introduce those mutations into the patient through a vaccine, we know that there's something there that if we get all the material in the right combination, we could hopefully elicit that type of immune response and hope that it's enough to have some impact on the cancer. And so we don't have immune cells from all of these 15 patients, but what we did in the first set of 6 is that 5 out of the 6, we were able to actually elicit T cell responses in 5 out of those 6 patients. The average predictive value of the short list that we went in was about 45%, meaning if we had about 20 mutations that we went in, we got about 9 or 10 out. And that's enough to make a multivalent vaccine with 10 epitopes that we know elicit an immune response in a dish, and we just want the opportunity to learn what that would do in a host if we were able to deliver that same vaccine to that individual. And then this is just the type of bigger data that we're trying to get, looking at the surface of the cell, so that immunopeptidomic technique, where we're pulling off these peptides, and we're finding that there's peptides derived from these hidden transposon elements and these endogenous retroviral elements that are being completely missed in the traditional way of sequencing the genome. And so there's even more material for us to go after and try to see if this actually improves our encatchment of neoantigens that we can go after and functionally validate and add to the pool of sequence-verified neoantigens that we've done so far. So I think the key takeaways from this is that cancer vaccines have been around for a long time. They fell out of favor, and now they're sort of making a resurgence since we have the ability to create mRNA at scale. We have different delivery methods that create immune responses like lipid nanoparticles, and we have evidence from adults that even in low mutational burden tumors like pancreatic cancer, we're getting immune responses in patients that are long-lived. That back seat that they took for a while was behind the workhorses of checkpoint inhibition and CAR T-cell therapy, but now that we're becoming more innovative with our vaccine design, we hope that there's an opportunity to combine that with checkpoint inhibition and or CAR T-cell therapy. And neuroblastoma is probably the worst one to start out with this endeavor because it has low MHC. That's the mechanism that the T-cells are going to see the mutations. They have low mutations overall, but I think that was a very high bar to clear, and we have some very early encouraging preclinical evidence that we can find new antigens, we can stimulate T-cells on a personalized basis, at least in a laboratory setting, and we're trying to at least get enough of a list of patients where we can validate that that exists to then create a clinical trial where the idea would be at biopsy, we get your mutation, you go through therapy, we create a personalized vaccine, we validate that on the patient's immune cells, and by the end of therapy, we can hopefully give you some immune surveillance to elicit T-cells responses from T-cells we know are circulating in the patient and give them extra protection to reduce the risk of relapse. None of this could be done without a very large team, collaborators at CHOP, Penn, La Jolla Institute for Immunology, and the bulk of this work is being supported by the NIH's Pediatric Immunotherapy Network. And with that, I'll take any questions.
Dr. Spear. Does anyone have any questions? No? No questions. You did good. Okay. So they've got it all down now. Thank you very much. Appreciate it. We're going to have one next speaker, although we have to do a little adjustment on the stage and everything. But is she ready yet? Let's see. Where'd she go? We met this young lady. Oh gosh, how old, Spencer? 3. She's 3? She was 3, and she's 17, right? 17 years old, and they had reached out. We see them on Facebook and everything, but to be able to have her come in and talk to the group and everything, what we like to do either each day or at the end of the day to just kind of, your heads are probably all swollen with information and everything, and what we try to do is give you that bit of hope, because a lot of times with all of this, chemotherapy, radiation, immunotherapy, all of it, it's just so overwhelming for you, and we just want you to know that, it can be beat, and we have a beautiful young lady standing in the back there who's going to come and talk and give you a little story about herself and what, where she's at and what she's doing, and hopefully we're going to get her a nice scholarship, I think. What do you think? Ava Crowley.
Good afternoon, everyone. My name is Ava Crowley, and I'm a 17-year-old at Ransom Everglades High School in Miami, Florida. I wanted to start by thanking Pat and Nikki for organizing such an amazing conference year after year. They do an incredible job curating a space for patients, survivors, and families in mind. I also want to thank all the parents who are here today showing up for their kids, because no parent should have to feel or watch your kids go through such a long and painful experience. Last time I was here, I was in the kids' playroom playing sock dodgeball. Today, I'm in the big kid room giving a speech to all of you. And I'm just 6 days away from being 11 years NED, no evidence of disease, on July 30th. Thank you. On May 1st of 2012, I was diagnosed at the age of 2 with stage 4 neuroblastoma, where I was treated at Nicklaus Children's Hospital in Miami. At the age of 5, in 2015, I relapsed and went to Memorial Sloan Kettering for the rest of my treatment. I knew life at the hospital, and I knew a life of everything else. I often called New York my second home after I would travel there every month to be treated. And although needles and tests were never my favorite part of being there, I was lucky to be able to experience so many other incredible things. The Candlelighters, an organization to keep the cancer off of kids' mind. Corporate Angel Network, who flew me around the country. And the Ronald McDonald House, who put up my family on 405th East 73rd Street, New York, New York, that had a giant basement playroom filled with crafts and games where I even met Superman. And the Memorial Sloan Kettering Hospital, where I knew every inch of the 9th floor, including the best elevators to use in my escape from bone marrow transplant. Every time I visited New York for treatment, my first thoughts were, can we go visit Barbara? She was my candlelighter. When I couldn't be at home with my dog Kaya, I could see Barbara and her adorable dog Uno. I remember she would take me to places like I was a regular kid. Shopping with her at Justice Kids, going to the sugar factory in Times Square, and playing with toys from her toy closet. We spent so much time together that her apartment doorman knew me every time we walked in. She even taught me how a real New Yorker gets a cab. Speaking of traveling in style, from time to time, the Corporate Angel Network blessed me and my parents with the comfort of our own private flight. One time, they surprised me with a Lion King flight. I was gifted with toys and a Lion King blanket I still have to this day. But most memorably was a Hakuna Matata menu themed, with Ava's favorite item on the menu, which was chicken tenders and French fries, of course. The pilots and flight attendants made this so special for me. I don't remember the number of times I was stuck with a needle or put in a scan. I remember the doctors and the nurses talking to them about the colors of the tops of the blood tubes, later learning that the prettier the tops were, the more blood they needed, or what prizes they had in their treasure chest. I remember my nurses and parents moving my iPad around the room so I could watch my movies during a scan, no matter what awkward position or direction I was facing. I remember eating Papa John's cheese pizza every other night at Nicholas Children's with my dad remarks, "I got one for us and a couple for the nurses." I never cared for the hospital bedding, the smell, or the feel. But I remember my 3 blankets. One I could lay on, one on top of me, and one over my pillow. I remember the hallways to the playrooms where I'd make crafts and had my 4th birthday party. They were the same halls where I ran to the elevators to avoid a bone marrow transplant. The same halls where I was told that the radiation and treatment I received when I was 3 and 6 meant I wasn't going to grow any bigger than I am today. From a survivor's perspective, patience, hope, and education are the most important pillars throughout treatment. In the words of a very wise man, Dr. Modak, this treatment is going to be long and hard, but learning patience will help you break it down into small steps. So focus your energy on what you can control. Being there to support your kids, whether you work, pray, or move for your child. In this life, false hope doesn't exist. Whoever tells you to conceal the faith you have in your child's recovery is wrong. What I can say about hope is never be afraid to speak it, and positivity. Encourage your child and yourself to be fearless. Every summer, I get to relearn how resilient children are, and they either reflect the strength and hope or the fear and doubt of the people who surround them. When I was in treatment, it never occurred to me what I was going through was so severe. Not because my family nor I wasn't educated, but because I never heard words of doubt or uncertainty come from the people surrounding me. I believe part of my living miracle is because of the loving community that starts in Miami. Through my Catholic elementary school community, I had loving classmates and teachers who participated annually in cancer walks for another student and me. The incredible nurses and individuals at the hospital who put in hours of hard work to make sure I was receiving my medicine properly and supporting my recovery. There are going to be scary, terrifying moments through treatment. It's a guarantee. Part of showing up for your child is also showing up for yourself, talking to your friends and family about it. But at the end of the day, in the hospital room, it's the words of faith, positivity, and hope that come out of your mouth that keep you and your child moving day by day. Lastly, but most importantly, education. With the amount of knowledge from books, doctors, and additional resources my parents gained about neuroblastoma from my treatment, they could write a novel as thick as War and Peace. So take the time to educate yourself on your child's treatment. While it's important to have trust in your child's care team and doctors, make yourself the expert so you're not left second-guessing yourself. What brought me here today is my passion for serving the pediatric cancer community. Back in Miami, I'm a volunteer of children and family experiences, as well as child life at the Nicholas Children's Hospital. During our events, the Fuchs Center, an on-campus center for children and families, provides crafts through the hospital and donations. I work with setting up events in the hospital lobby for inpatients, outpatients, and their families, as well as often participating in the crafts myself, while engaging in meaningful conversations with the patients and families, whether about their favorite songs, movies, or a hard day of treatment. As part of my job at the Fuchs Center, I restock coffee, thoroughly wipe down used surfaces, and my favorite, laundry. The Fuchs Center truly provides a wonderful and inviting atmosphere where children of trauma can be seen, where they can feel at home. And volunteering has allowed me to directly give back to one of the major hospitals I was treated at. This summer, alongside volunteering at Nicholas, I'm completing the Bowden Fellowship through my high school, researching the effectiveness of bibliotherapy, the use of books, poetry, and literature to support mental health and healing in children's hospitals. My research question is, how can survivor-led children's literature center the voices of pediatric cancer patients and serve as a tool for comfort, preparation, and healing? I'm studying how reading to patients undergoing long-term treatments like immunotherapy, chemo, and radiation can help prepare them emotionally, offer support, and comfort them. Along the way, I've had the privilege of hearing other patients' and family stories and sharing my own experience alongside them. At the end of my fellowship, I'll write a children's book centered on the comfort, preparation, and emotional healing, a relatable narrative for patients in treatment, and a resource for family and friends they can turn to as well. I'm passionate about creating a story that truly connects with and supports pediatric cancer patients, their families, and their communities. I believe that writing and sharing a narrative crafted for pediatric cancer patients will contribute positively to their recovery. I'll close out now, but as a senior, I've also started writing my personal statement. You can imagine what it's about. There's no exact method to tell you and your child how to go through this treatment, but if I can leave you with anything today, learn patience, hope, and learn to educate yourself for your child. You're all taking time to be here today and listen to these amazing doctors. And even though you're going to be spending the majority of your time in hospital bedrooms and waiting rooms, I encourage you to hang on to the bright moments with your child. Luckily, they're at the age where they won't remember most of their treatment. But creating those bright moments and hanging on to them in times of fear and uncertainty will only help the process of emotionally recovering from this disease easier. Because if you believe in them, they will believe in themselves. And there's no stronger medicine than a fearless and resilient child. Thank you all very much for having me up here. Have a great rest of your day.
Thank you so much. It was beautiful. We just, again, love having all of you come to this because of the learning. We want you to learn as much as you can. Know that there are so many doctors and nurses and statisticians and scientists doing this research to try to find a cure. You know, unfortunately, it's not here yet. But, you know, please have faith. You know, please keep working. And people like Ava are just, you know, an incredible positive force for us. And I just want to thank you very much for coming and being a part of it. And get ready for tonight. 6:30-ish, dinner, dancing, head spin. So whatever you're into, we hope you enjoy yourself. We'll have dinner right next door.